हेलो।
ચેરપર્સનનું નામ છે ને ડાયરેક્ટ ચેરપર્સન સાથે બોલી
हेलो हेलो।
એક મિનિટ
हेलो हेलो
हेलो हेलो हेलो हेलो हेलो हेलो चेक 1 2 ठीक
हाँ इन्हें हम ऑनलाइन जानकर
Unmute करें. Hello, good morning. Good morning, all. I am Dr. Jitendra Patel speaking from Ahmedabad, from Hall I, and we are starting the session of 6th of November. Now I request our technical partners to start the session. Simran, please start the videos. Thank you.
The mean versus group was least in group RD, while maximum in group RC. Duration of anesthesia was maximum in group RD, which was 7.7 hours in group RD, while 4.5 hours in group R and 2.7 hours in group C. Total repair requirements was maximum in group C, which were 223 milligram and 160 milligram group R, and least in 116.6 milligram in group RD. Patient satisfaction.
Two different volumes of local anesthetics in ultrasound guided interscalene brachial plexus block on incidence and recovery of phrenic nerve block in patients undergoing upper limb surgery. Background and aim. Ipsilateral phrenic nerve blockade is a common adverse event after an interscalene brachial plexus block. The aim of this study is to estimate the incidence of phrenic nerve palsy and duration for its recovery in interscalene block by comparing two different volumes of local anesthetic. Introduction. Interscalene brachial plexus block is one of the most reliable and commonly performed technique for regional anesthesia of the upper part of the upper extremity. It anesthetizes the caudal portion of the cervical plexus and the superior and the middle trunk of the brachial plexus. It is associated with a number of complications, but the most common is phrenic nerve palsy that occurs in 100% of patients using current techniques. Phrenic nerve arises chiefly from the C4 root with variable contributions from C3 and C4. Phrenic nerve is associated with a significant reduction in ventilatory function. Ultrasonography can be used to identify brachial plexus anatomy, guide needle placement, and visualize local anesthetic spread. This technique may improve correct placement of anesthetic and minimize complication because individual nerves can be more effectively located and lower volumes of local anesthetic directed around target structures. In this study, we hypothesized that by reducing local anesthetic volume during ultrasound guided interscaling block, it is possible to reduce the incidence, severity, or both of phrenic nerve block without sacrificing quality or duration of analgesia after upper limb surgery. Methodology: study design was prospective randomized control trial done in Government Rajaji Hospital, Madurai for a duration of 6 months. Collaborating department was orthopedic surgery. Institutional ethical committee approval obtained. Sample size calculated from pilot study of 10 patients done in our hospital. Sample size calculated 50. Power of the study 80%. Confidence interval 95%. Study population: patient aged 18 to 50 years undergoing upper limb surgery under interscalene block who are randomly allocated into 2 groups. Done in 50 patients, 25 in each group. Group 1 receiving 10 ml and group 2 receiving 20 ml. Diaphragmatic movement, analgesic effect, and recovery time was assessed. Inclusion criteria: age 18 to 50 years, ASA 1, 2, 3, BMI less than 35. Exclusion criteria: pre-existing COPD, unstable angina, psychiatric disorder, renal or hepatic impairment, allergy to local anesthetics. Primary outcome: to assess diaphragm movement and analgesic effect. Secondary outcome: recovery time of phrenic nerve block. Methodology: the procedure was informed and written consent was obtained. Thorough pre-anesthetic checkup for all patients done. 50 patients undergoing upper limb surgery were randomly enrolled into 2 groups. Group 1 received 10 ml of local anesthetic and group 2 receives 20 ml. Injection: Rantac 50 and metoclopramide 10 mg IV given early morning before surgery as a pre-medication. In the operation theatre, standard monitors are attached to the patient. Patient is assessed for diaphragmatic movement pre-operatively before giving block. Using ultrasound and other parameters are also measured. Patient position, parts painted and draped. Ultrasound guided interscalene brachial plexus block was given for both the groups. Group 1 receiving 10 ml and group 2 receiving 20 ml of local anesthetic. Patient analgesic effect was assessed. Sensory by pinprick at ulnar diaphragm movement assessment by ultrasound. Consult flowchart: 65 patients were eligible. Among 4 was excluded under exclusion criteria. 10 refused to participate. 1 was unable to assess and randomized into 50 patients. 25 in each group. 1 low group receiving 10 ml and other standard group receiving 20 ml. Parameters observed: diaphragmatic movement using ultrasound, analgesic effect, recovery time of phrenic nerve blockade, oxygen saturation, and PFR. Movement of diaphragm: diaphragm movement was marked as present in patients whose post-block movement of diaphragm was to the same extent as that was observed in pre-block status by ultrasound, and marked as absent in patients where there was even a mild decrease when compared with pre-block extent of diaphragmatic movement. Patient was said to be recovered from phrenic nerve block when the patient attained 100% present in pre-block status. Statistical analysis: the results were analyzed by student t-test. Observation results: 34% of female patients and 66% of male patients. Loss of diaphragm movement 30 minutes after block. 60% in group 1 experienced diaphragm and 100% in group 2. 97 in group 1 and 95 in group 2. Discussion: the result of this study demonstrates that administration of a block respiratory function while providing equal analgesia, standard volume. Lower guidance can improve the overall efficacy. Ultrasound allowed us to visualize the brachial plexus at the interscalene groove and administer a lower volume of local anesthetic at the nerve root. This resulted in lower incidence of phrenic nerve palsy and better preservation of respiratory function in terms of PFR and oxygen saturation compared with standard group. Furthermore, analgesia was similar between the both groups, indicating that local anesthetic, that is 10 ml, can spread sufficiently to anesthetize the upper extremity while sparing the phrenic nerve. Therefore, these findings provide evidence in support of the use of low volume local anesthetic for interscalene block for upper limb surgery. A lower volume of local anesthetic in an ultrasound guided interscalene block is associated with the improved respiratory function while providing effective analgesia compared with standard group. We found that 100% of patients receiving standard volume of local anesthetic for interscalene block experienced hemidiaphragmatic paralysis and reduced lung function. In this study, the decrease in respiratory function led to significant reduction in oxygen saturation high group. Also, our findings indicate that the incidence of hemidiaphragmatic paralysis was significantly lower with the low volume group. It nevertheless can still occur. A study done by Riasi and colleagues using 5 ml versus 20 ml in patients undergoing shoulder surgery also had 45% incidence of phrenic nerve blockage. In this study, we found that 60%, 15 out of 25 patients of the low volume group still experienced phrenic nerve palsy. Limitations, it should be noted that without ultrasound, we do not know if a 10 ml of local anesthetic is sufficient for interscalene block. The ultrasound approach allowed for a precise deposition of local anesthetic around the nerve root. Although the instance and duration of phrenic paralysis can be reduced with a low volume ultrasound guided technique, it cannot be avoided entirely. Conclusion, this study concludes that USG guided interscalene block in low volume group is associated with a lower incidence of phrenic nerve palsy, faster recovery, and effective anesthesia compared with standard volume group. These are the references.
कहाँ से कनेक्शन कहाँ से मेरा इसमें जा रहा है क्या आवाज जाएगी क्या इन्हीं से प्रॉब्लम हो रही है क्या
टेक्निकल टीम एक कंप्लीट हो चुका है अभी दूसरा आएगा
The co-host has asked you to
start your video. Start my video.
Now we are starting second paper, research paper.
Hello. Hello.
Hello.
Can you hear me? Hello.
Yes, you are audible.
Okay. Doctor, I am too late. What is your topic? Hello.
My topic was effect of local anesthetic on phrenic nerve palsy, ma'am, by comparing two volume ml and 20 ml.
Your voice is not clear. Hello.
Ma'am, am I audible, ma'am?
Yes, you are audible.
I'm comparing two different volumes on effect of phrenic nerve movement palsy.
Comparison of two?
Two volumes, ma'am. Two volumes of local anesthetic and diaphragmatic movement, ma'am.
Which local anesthetics?
Ma'am, Bupivacaine.
Bupivacaine. In which concentration?
Ma'am?
Which concentration?
Ma'am, on a diaphragmatic movement, ma'am. By comparing volume.
By compile volume. How much volume?
Ma'am, group 1 receives 10 ml and group 2 receives 20 ml, ma'am.
That any complication you have seen?
Ma'am, group 2, there will be intense motor blockade. A patient will be, ma'am?
In group 2, intense motor blockade of?
Motor blockade, ma'am. So patient won't be able to lift the hand. Phrenic nerve recovery was quicker in group 1 compared to group 2, ma'am.
Any respiratory complication?
Group 2, PFR will be reduced, ma'am. Respiratory, ventilatory functions will be reduced comparing with group 1.
Which concentration of bupivacaine you used?
Ma'am, I can't.
Concentration.
Concentration 0.25%.
Okay. Okay, thanks. Okay, thanks.
Thank you. Now we are going to next research paper. Here,
बहुत ही प्रॉब्लम है इनका टेक्निकल। अभी एक दिन बहुत अच्छे से चल रहा था।
Ma'am, just give us a second. We're playing the next video.
Okay.
Good day, everyone. I'm Dr. Bindu. My title for today is Comparison of Hemodynamic Response to Intubation between Macintosh Laryngoscope and Kingvision Video Laryngoscope in controlled hypertensive patients, an observational study under the guidance of Dr. Sherry Matthews and Dr. Deepraj Singh. Direct laryngoscopy and passage of endotracheal tube through the larynx can provoke untoward hemodynamic response. The elevation of arterial pressure typically starts within 5 seconds of laryngoscopy and peaks in 1 to 4 minutes and returns to control values within 5 minutes. The increase in heart rate and blood pressure are brief and variable. They are more marked and unpredictable in patients with hypertension, primarily because of increased activity of sympathetic nervous system with sensitivity of peripheral vessels to catecholamine. An exaggerated response has been reported in hypertensive patients due to the stimulation of the supraglottic region by tissue tension induced by laryngoscopy. King's Vision Video Laryngoscope provides a high-quality image of airway structures displayed on a video screen. Visualization can be done without alignment of the oral, pharyngeal, and tracheal axes, thus decreasing the tissue tension induced by laryngoscope and subsequent catecholamine response to intubation. Aim is to compare the hemodynamic response to intubation between Macintosh laryngoscopy and King's Vision Video Laryngoscope in controlled hypertensive patients. The objectives are to study the upper airway morbidity, esophageal intubation, mucosal bleeding, lip, dental injury, and desaturations. The study was conducted with written informed consent in our institution after approval from the Institute Ethics Committee. Inclusion criteria is of patients with hypertension controlled on antihypertensive medication scheduled for elective surgery under general anesthesia and requiring orotracheal intubation. Exclusion criteria include age less than 18 years with a history of coronary artery disease, difficult airway or history of difficult intubation with a BMI of greater than 30, cervicospinal diseases, gastroesophageal reflux, and patients with requiring rapid sequence induction. The patients were randomized into two groups of group M and K, each of 40, based on computer-generated random number list. The sample size is calculated using EpiInfo software, and the sample size is calculated with N80, standard deviation of 20, and a confidence limit of 95% with a power of 80%, and the ratio between experimental and control group being 1:1, anticipating a difference of 20 millimeters of mercury in the mean arterial pressure. Pre-anesthetic assessment was done by a cardiologist to optimize their antihypertensive treatment and exclude other cardiac abnormalities. Airway examination, Mallampati scoring, thyromental distances, interincisor distances, and antihypertensive medications used by the patients were charted. Pre-operative preparation with fasting overnight and oral induction. Intraoperatively cannulated with 18 gauge and given midazolam 0.02 milligrams per kg intravenous. Monitored with a 3-lead electrocardiogram, non-invasive blood pressure, pulse oximeter, and the baseline values of systolic blood pressure and diastolic and mean blood pressure and heart rate were recorded. 5 minutes of pre-oxygenation with 100% oxygen, induction with fentanyl and propofol according to body weight, neuromuscular block was achieved with vecuronium according to body weight, and the patient was ventilated with 50% of oxygen and nitrous lead and 1.5% isoflurane using face mask. All intubations were conducted by a single experienced anesthesiologist with more than 10 years of experience. Monitoring of heart rate, BP, saturation, end-tidal carbon dioxide, number of intubation attempts, and total intubation time. Demographic data was tabulated on the parameters of age, gender, weight, height, Mallampati scoring, and mouth opening greater than 3 finger. No significant p-value. And demographic data of antihypertensive medication taking the baseline hemodynamic parameters of heart rate and blood pressures are comparable between the two groups. The heart rate of the Macintosh group significantly increased at intubation up to 4 minutes following tracheal intubation. In the King's Vision Video Laryngoscopy diastolic blood pressure increased at intubation up to 4 minutes and was statistically significant as compared to the baseline. The intergroup analysis showed significant increase in the blood pressure at intubation in both the groups as plotted here. Secondary objectives was to tabulate the intraoperative airway complications, time to intubate, number of attempts, and esophageal intubation. It showed that there was a significant p-value for the time taken to intubate, clearly showing that it took less time for Macintosh intubation. And hemodynamic responses to intubation were tabulated, and there was a significant p-values from intubation till 4 minutes in the heart rate and blood pressure noted. King's Vision video laryngoscope led to significantly less increase in blood pressure following intubation compared to Macintosh. Heart rate significantly increased in the Macintosh group. Hemodynamic response to intubation is because of stimulation of oropharyngeal structures. Similarly, the upper limb muscular activity and perceived workload was found to be significantly lower in participants using King's Vision video laryngoscope compared to Macintosh. There was other references in literature by Mona M. Mehmet comparing Macintosh and channeled King Vision and CMAC blade in controlled hypertensive, showing that there was a significant increase in the heart rate and mean blood pressure in the Macintosh group. In agreement to our finding, El Hadi in his study demonstrated that King Vision video laryngoscopes maintain hemodynamic stability during endotracheal intubation follow, especially in hypertensive patients. Gamzee Circular conducted a study in patients posted for major cardiac surgeries, where intubation was performed between video and direct laryngoscopy. There were minor changes in the cardiac hemodynamics throughout the study in both the groups. And conclude that the King's Vision video laryngoscope reduces the hemodynamic response to intubation because of its less compression to soft tissue structures and the better glottic visualization, which reduces esophageal intubation and the upward lifting forces compared to Macintosh. Incidence of post-operative complications, sore throat, hoarseness, cough was similar in both. Our studies conclude that King's Vision video laryngoscope is superior to Macintosh laryngoscope in controlled hypertensive patients for decreasing the hemodynamic responses to intubation. My references are these. Thank you.
Yes, Dr. Bindu.
Good morning, madam. I am Bindu.
Good morning, Dr. Bindu.
Good morning.
What was the baseline level of your in both the groups?
Madam, we had controlled hypertensive, ma'am. We've taken a baseline value of anything less than 130/90, ma'am.
In both the groups?
In both the groups, ma'am.
Okay. And which was the highest limit of the mean arterial blood pressure in with Macintosh laryngoscope?
It was higher in Macintosh, ma'am.
Okay. What was the limit of?
We've had a value of around 195/105, ma'am. Immediately post intubation.
Immediately after post intubation.
Immediately, yes.
In what time it touches the baseline?
Ma'am, it was. Ma'am, it was variable, ma'am, but mostly in all, on an average, it was after 3 minutes, ma'am, 3 to 4 minutes.
And with the KVVL laryngoscope?
KVVL was lesser, ma'am, by around from 2 to 3 minutes, it was baseline, ma'am, and closer to baseline.
What was the extent in KVVL mean arterial pressure, highest?
Ma'am, highest was 160, ma'am, 165/85.
Then any significance of within 1 to 4 minutes of in both the groups?
Yes, ma'am.
Regarding mean arterial blood pressure?
Yes, ma'am. It was always higher for Macintosh group as compared to King's Vision markedly.
Okay, and what's about pulse rate?
Pulse rate was much higher for Macintosh, ma'am. The significance between Macintosh and King's Vision was not so drastic as compared to the significant change in the BP.
But we are routinely not seen this much of pulse rate and the blood pressure in normal patients.
Yes,
in controlled hypertensive agent, we are routinely use the Macintosh blade, no?
Yes, ma'am.
We are all over.
We used King's Vision, ma'am.
And you use in pre-medication alprazolam at night, and in the morning you give the fentanyl and midazolam as a pre-anesthetic agents, no?
Yes, ma'am. We routinely use that in our hospital.
And I am,
So,
but this is too much, no? 190 is the too much.
yes,
And
ma'am.
in a controlled hypertensive, I have never seen this extent of blood pressure.
Oh,
Okay, thanks. Okay,
thank you,
thanks,
ma'am.
Dr.
Hello.
Bindu.
Thank you, ma'am.
Excuse me.
Yes,
Hello, madam. We are running
yes.
short of time. So
Okay, okay. Okay, okay.
please move to the next
Okay,
paper. Thank you so
okay,
much.
okay. Okay. Renisha, move to next.
Yes, ma'am.
Hello everyone, I am Dr. Sasiraj from KGMU Lucknow. I am going to present free paper on ultrasound guided quadratus lumbarum block versus transverse abdominis plane block for laparoscopic inguinal hernia repair and appendicectomy using ropivacaine with dexmedetomidine. Elevating pain during intraoperative and postoperative period is one of the major concerns to anesthesiologists. Infraumbilical surgeries like laparoscopic inguinal hernia repair and appendicectomy has been associated with severe pain and has morbidity and mortality. Quadratus lumborum block and TAP block has been found to be quite effective with respect to pain relief for infraumbilical surgery like laparoscopic inguinal hernia repair and appendicectomy. Quadratus lumborum block and TAP block are newly rapidly expanding regional anesthesia technique that provide analgesia following lower abdominal surgeries. TAP block via triangular petit blocks the sensory nerve of anterior abdominal wall before they leave the plane and pierce the muscles to innervate the anterior abdominal wall. Quadratus lumborum block provides superficial sensory as well as deep somatic analgesia by blocking lumbar nerve root within transverse abdominis plane block. The quadratus lumborum block relieves somatic pain as well as visceral pain. This study will show the comparison between quadratus lumborum and TAP block in laparoscopic inguinal hernia repair and appendicectomy using ropivacaine and dexim in terms of analgesic efficacy, so that we can provide a unique modality for pain relief. Aim will be to compare the quadratus lumborum block with TAP block for laparoscopic inguinal hernia repair and appendicectomy using ropivacaine with dexim on following objective. Primary objective will be to assess the quality and duration of postoperative analgesia, and secondary objective will be hemodynamic effect, need of rescue analgesia for 24 hours, and side effects and complication of blocks. This study was registered with CTRI after clearance from the ethical committee. Total study duration is 1 year, and prospective randomized single blind study will be going. Sample size 64 cases included in this study, in with 32 in each group. Group A will be given a quadratus lumborum block, and group B will be given a TAP block. Inclusion criteria: age between 20 to 50 years with ASA grade 1 and 2. Patient giving informed and written consent will be taken. Patient for laparoscopic inguinal hernia repair and appendicectomy. Exclusion criteria: ASA grade 3 and 4, infection at the site of injection, allergy to study drug, localized malignant tumor, heart block, pregnant patient, lactating patient, difficulty in communication with patient, and technically difficult block. All patients will be divided into two group by cheat method. Group A, quadratus lumborum block. Group B, TAP block. All patients will be operated under general anesthesia. On the day of surgery, after confirming adequate NPO status, the IV line secured, and patient will be pre-medicated with injection ondansetron, injection midazolam, and injection fentanyl. Patient will be induced with injection propofol and injection vecuronium. Maintenance of anesthesia by nitrous oxide, sevoflurane, or oxygen, and injection vecuronium and injection fentanyl 1 microgram per kg every hour. TAP block or quadratus lumborum block will be given after induction of anesthesia and before incision. Primary requirement will be ultrasound machine, ultrasound probe cover, antiseptic for skin disinfection, sterile ultrasound gel, needle, and 20 ml syringe. Experimental quadratus lumborum block with 0.5% ropivacaine and 20 ml with dexim 0.5 microgram per kg deposited in quadratus lumborum muscle under ultrasound guidance. An experimental TAP block with 0.5% ropivacaine 20 ml with dexim 0.5 microgram per kg deposited in TAP plane under ultrasound guidance. P value of less than 0.05 were considered significant. In this chart, you can see no pain was observed at 0 hour in any of the patient. Pain of about 2 was comparable at 6 hour, at 12 hour, 18 hour, and 24 hour. Level of pain of group B were found to be significantly higher than group A. Patient of group B required first dose of rescue analgesia significantly earlier than group A. No rescue analgesia were required by 43.8% of patient of group A. Mean arterial pressure of both the group were comparable at baseline and thereafter at the all periods of observation till 6 hours. At 12 hour, 18 hour, 24 hour, mean BP of group B was found to be significantly higher than of group A. The result of our study demonstrated that quadratus lumborum block was more effective than transversus abdominis plane block. Visual analysis score and first call for rescue analysis indicate the superiority of quadratus lumborum block over TAP block. There is highly significant difference in postoperative visual analog score and postoperative first call for rescue analgesia required between both groups. Postoperative time after which the rescue analgesia dose is required was significantly more for group A, quadratus lumborum block group, than group B, TAP block. Similarly, our result agreed with conclusion of the Gaussian and his co-workers study, and also Kalpana Verma and co-worker study that time for rescue analgesia requirement was higher in quadratus lumborum block group than TAP block group. According to this study, we can conclude that quadratus lumborum block will be better option for providing postoperative analgesia during laparoscopic inguinal hernia repair and appendicectomy using ropivacaine with dexmedetomidine in terms of duration for requirement of first rescue analgesia, better pain score at rest, and total rescue analgesic consumptions. Thank you.
Ma'am, please unmute yourself. You are not audible.
Hello.
Good morning,
Good morning. Quadratus lumborum block is superior than TAP block. Then, what was the total amounts of rescue analgesia required in both the blocks? In milligram or doses?
Ma'am, for TAP block group, maximum rescue analgesia we needed 2 gram PCM, and in some patient we need 75 mg of diclofenac. Or for quadratus lumborum group, the rescue analgesia need is about totally around 1 gram of PCM after at 18 to 24 hours post-operatively.
Okay, what was the extent or endpoint of your study?
24 hours, ma'am, post-operative 24 hours.
Okay, thank you.
Thank you, ma'am.
Okay, Ganesha, move to next.
Okay. Now this is done for next research paper.
क्या ले रहे हैं विषय में? जी में
Ma'am, should I play the next video?
Yes, yes.
Okay.
Hello everyone, I am Dr. Shalini Nangalia, postgraduate trainee from Isacon Medical College, Kolkata. Today I am going to present my topic, ROX index validity in predicting early the need for invasive mechanical ventilation in COVID-19. So ROX index is the ratio of pulse oximetry divided by fraction of inspired oxygen to respiratory rate. It is a simple calculation using 3 clinical variables which helps to determine a patient's degree of hypoxemic respiratory failure, which is of particular importance in COVID-19. The aims of my study were, the primary aim was to calculate ROX index and to validate in predicting early the need for invasive mechanical ventilation in COVID-19 patients on high flow nasal therapy or BiPAP. The secondary aim was to calculate the percentage of patients who failed HFNC and were needed to progress to intubation for further ventilatory support. My study was retrospective and observational, and it was conducted in COVID-19 critical care unit of Isacon Medical College over a period of 3 months on a sample size of 70 patients with laboratory confirmed COVID-19 on HFNO or BiPAP. The data that was collected were medical history, age, sex, comorbidities, COVID-19 infection clinical classification was done into moderate or severe. Radiological findings were noted, and ROX index was measured at 2, 6, and 12 hours post high flow nasal cannula initiation and thereafter 12 hourly. Laboratory biomarkers were noted. So on initiation of high flow nasal cannula, a ROX index was measured, and the predictors of high flow nasal cannula success included the following, and the predictors of high flow nasal cannula failures included the following. So according to my statistics, the collected data was put into a Microsoft Excel worksheet, and based upon the distribution, the data was presented as either mean or median. Frequencies and percentages were used to present nominal variables. An ROC curve was used to determine the most accurate cutoff point for prediction of intubation. A p-value less than 0.05 was considered significant. The results were, the study was included in 70 patients with mean age being 53 years old, and the clinical characteristics of patients were age, sex, and comorbidities. So among my participants of 70, moderate cases were 45 and severe cases were 25. Among the moderate cases, 38 patients required intubation, and among severe cases, 97 patients required intubation. Now, this is the ROX index management guidelines for high flow nasal cannula. So this is a graph depicting two groups, the first group being on HFNT and the second group being on high flow nasal therapy, which had to be progressed to invasive mechanical ventilation. A ROC curve was done, which predicted the need for using IMV, and accurate cutoff point was determined. So clinicians could use the ROX index to assess progress in COVID-19 patients, and it is a useful predictor of HFNC in COVID-19 respiratory failure. So I conclude that ROX index is a simple non-invasive tool for predicting discontinuation of HFNT and could be used in assessment of progress and risk of intubation in COVID-19 patients. The limitations that my study is retrospective and single center nature. These are my references. Thank you.
Hello. Hello.
Yes.
Yeah. Are you listening me?
Yes, you are audible.
Okay. Have you seen any relation of comorbidities like diabetes or hypertensive patient requiring more chances of intubation after HFNC use? Hello.
I think
Find out Dr. Shalini hasn't joined the team. Shalini ma'am hasn't joined. Am I audible, ma'am?
Yes, yes.
Ma'am, I think Dr. Shalini hasn't joined yet.
Okay.
So should we move on to the next?
Okay, move to next.
Ma'am, yes, ma'am, we can move on to the next video.
Yes, yes, move to next video. Yes, yes.
Glossopharyngeal nerve block and combined glossopharyngeal nerve block post-operative pain relief in children undergoing tonsillectomy. Background: post-op pain relief due to glossopharyngeal fiber irritation and secondary hemorrhage are important complications following tonsillectomy surgery. Blocking the fibers of glossopharyngeal nerve that supply the tonsils and cryoanesthesia are both found to be effective in alleviating post-operative pain in children undergoing tonsillectomy. This study aims to compare three modalities of pain relief, namely cryoanesthesia, glossopharyngeal block, and combined glossopharyngeal nerve block with nebulized ropivacaine that can be used in these surgeries. Primary objective is to compare the effectiveness of these three modalities of pain relief, namely cryoanesthesia, glossopharyngeal block, and block following nebulized ropivacaine on post-op pain relief in tonsillectomy patients. Secondary objective is to compare the safety of these three modalities of pain relief. Methodology is a randomized control trial conducted in Government Rajaji Hospital, Madurai for a duration of 6 months. Collaborating department was the Department of Otorhinolaryngology. Institution Ethics Committee approval was obtained. We included children of age 8 to 12 years undergoing tonsillectomy surgery under general anesthesia. Sample size based on previous studies, setting the power of study to 80% and confidence interval 95%. We calculated sample size to be 20 patients in each group. Inclusion criteria, we included children of age 8 to 12 years undergoing tonsillectomy, ASA 1 and 2, BMI 30 to 20 kg per meter square. We excluded children with URI or LRI recently and receiving regular analgesics prior to surgery with peritoneal abscess or with hypersensitivity to local anesthetics. This is the consort flowchart. Enrollment. We screened 18 children for eligibility, of which 10 were excluded due to the factors mentioned before. 70 were invited to participate, out of which 63 patients gave informed consent. 3 were not included because of URI or LRI, and remaining 60 patients were allocated randomly to 3 groups A, B, and C. Receiving in Group A cryoanalgesia, Group B bilateral prostatopharyngeal block following surgery, and Group C bilateral prostatopharyngeal block following surgery and nebulized ropivacaine after extubation. Patients were followed up to 6 hours post-operatively and assessed for pain and post-operative complications. Follow-up and analysis, no patient lost to follow-up and all the 60 patients were analyzed. After inclusion in the study, children were randomly allocated into 3 groups A, B, and C. General anesthesia was induced and maintained in similar manner in all the 3 groups, and bilateral tonsillectomy done by the same surgeon in all the patients. Study intervention, Group A, B, and C. Group A received cryoanalgesia with supercooled nitrous oxide following surgery. Group B received bilateral prostatopharyngeal block with 3 ml of 0.25% ropivacaine each side following surgery. And C received bilateral block following surgery and then nebulization with 3 ml of 0.25% ropivacaine following extubation. Patients were assessed for gag and swallow reflex before extubation, and only those with intact swallowing reflex were extubated. Postoperative flag score was assessed with rest and swallowing at 10, 20, 30 minutes and 1, 3, and 6 hours post-surgery. Rescue analgesic with paracetamol was given to those who had flag score more than or equal to 6 at 10 minutes after extubation. The picture shows a cryoprobe delivering supercooled nitrous oxide to each tonsillar fossa for 1 minute. Glossopharyngeal nerve block mouth opening was done with a Boyle-Davis gag, and 25 gauge Quincke spinal needle was used. Technique: at midpoint of the posterior tonsillar pillar, needle pierced the retropharyngeal mucosa and to a depth of 0.5 cm. 3 ml of 0.25% ropivacaine was slowly injected over each side or for a span of 1 minute on each side. Parameters observed: flag score at 10, 20, 30 minutes, 1, 3, and 6 hours following extubation. Flag score and rest and swallowing at same time intervals were measured. Need for rescue analgesic at 10 minutes post-extubation. Severity of throat pain, response to gag reflex, post-operative complications like bleeding, nausea, vomiting, perioral numbness, foreign body sensation were assessed. This is the flag score which was used in the study. It is a pediatric pain score. Results: statistical analysis. Continuous variables were analyzed were expressed as mean standard deviation or median with interquartile range. Categorical variables were expressed as numbers and percentages. Continuous variables are compared using Kruskal-Wallis test, and categorical variables using chi-square test of significance. P-value of less than 0.05 was considered to be significant. This table shows demographic details. The age, gender, BMI, and duration of surgery were comparable among all the 3 groups, and p-value was more than 0.05 in all the categories. This is a table showing flag score at rest. You can see from the table that in Group C, the flag score was significantly reduced in the early postoperative period, that is in the first hour following extubation. The p-value was less than 0.05 in all the 4 periods. This is also depicted in the line diagram. Flag score at swallowing, we can see that the p-value was very significantly reduced in Group C. That is, the flag score was very significantly reduced in Group C at all the times of measurements compared to Group A and B. Regarding throat pain in the postoperative period, we can see that in Group C, 90% of the patients had no to mild pain. That is, the throat pain was reduced significantly in Group C compared to the other 2 groups. And also moderate to severe pain, that is, higher degrees of throat pain was more commonly seen in Group A, which is also significantly more. The need for rescue analgesic in the first 10-minute post-op. In Group A, 80% of the children needed rescue analgesic in the first 10 minutes post-extubation, which was statistically significant. Out of those who required rescue analgesia, 53% belonged to Group A. Response to gag reflex, we can see from the table that the gag reflex was significantly suppressed to just a grimace response in 13 patients in group B and 14 patients in group C, which was significant statistically. And the response was brisk with restlessness in about more patients in group A. Post-op complications like bleeding, nasal obstruction, local acid toxicity was not seen in any of the patients, and foreign body sensation was seen in 7 patients in group A, but this was not statistically significant. The same is depicted in this chart. Summary: Clark scores in the immediate post-op period, that is the first post-operative hour at both rest and swallowing, was significantly less in group C compared to the other groups. Need for rescue analgesic was significantly more in group A in the first hour. Suppression of gag reflex was comparable between group B and C and was significantly more than group A. Post-op adverse events like bleeding and local acid toxicity was not seen in any patient. Merits: this is one of the few studies comparing 3 modalities of pain relief in tonsillectomy patients. And limitations are that we use a smaller sample size and absence of preoperative evaluation of gag reflex, and though lot complications like loss of protective airway reflexes and airway obstruction not seen in any of our patients, they can still occur in other patients receiving the block. To conclude, bilateral glossopharyngeal nerve block with nebulized lopivacine provided superior post-op analgesia and significantly reduce the need for rescue analgesic in the early post-op period, can be safely used in children undergoing tonsillectomy. These are my
Good morning, ma'am.
Have you seen? Hello, doctor.
Hello, good morning, ma'am.
Good morning. Have you seen any less bleeding in operative area with any of glossopharyngeal block or cryoanalgesia?
Sorry, ma'am, it's a bit not clear.
Okay. Did you observe the bleeding at the operative site?
Bleeding? No, ma'am, there was not significant bleeding in any of the study participants.
Not significant bleeding. Or it was less with cryoanalgesia?
Sorry, ma'am, cryoanalgesia?
There was no difference between the bleeding at the operative site in all 3 modalities. Okay.
No, ma'am. So for reducing that, we tried to use. So we kept in mind that complication and we tried to reduce it by using spinal tables.
Total analgesic consumption in all 3 groups in doses or milligram. Which rescue analgesics you used?
Paracetamol.
Paracetamol. And how much dose?
15 mg per kg.
Okay, thanks.
Dose of anesthetic we used 1 to 2 mg per kg in each 3 ml of 0.25% ropivacaine for each block.
And endpoint of your study? After how many hours you end your study? You observed the patient in postoperative period for 8 hours or 24 hours?
6 hours.
6 hours. Okay, thanks. Okay, thank you.
Thank you.
Now let's move on to the next research paper.
Morning, everyone. Thanks for giving me the opportunity to present in Isacon 2020. I am Dr. Badal from Tata Memorial Hospital, Mumbai. I am going to present my topic. It's a single-center, double-blinded, randomized study evaluating the role of thoracic spine ultrasound pre-scan for epidural catheter insertion in patient doing cancer surgeries. As we all know that the thoracic epidural analgesia is known to have a superior perioperative pain control over IV opioid following the open thoracic and abdominal surgeries. Though the epidural needle insertion and catheter placement are historically a blind technique, but recent times ultrasound guided epidural catheter placement technique is gaining popularity in the various parts of the world. In this study, we compared conventional clinical technique versus USG scan for successful epidural placement in mid-thoracic level, that is T5 to T8. Our aims were to study the role of USG scan in T5 to T8 level for guiding the entry point for epidural catheterization in comparison to the conventional surface landmark technique. Primary endpoint was comparing the two techniques for the first attempt success, and the secondary endpoint were difference in the number of attempts, passes needed, and complication rate. A new skin puncture or a complete withdrawal of needle from entry site known as attempt, whereas redirection of the needle after entry during the procedure considered as pass. After the approval from the ethics committee and CTI registration, the patients who were posted for thoracic upper abdominal surgery were included in the study. Epidural insertion was done in the lateral position by paramedian approach. The patient were randomized as per computer charts after the preparation of back and draping. The trainee as well as performing the epidural was blinded. In clinical group, the consultant marked the entry point after conventional bony landmark technique, that is the 1 to 1.5 centimeter lateral to the superior border of the spine, whereas in USG arm, using a parasite oblique view, laminar and interlaminar spaces were identified and the superior border of the lamina was marked. Like you can see in the slide that the A point is the superior border of the lamina. The performance was allowed one attempt and maximum of 3 passes. An independent observer noted the number of passes. In each group, there were 43 patients. One is clinical arm and one is ultrasound arm. Both the groups, they were matched for the above variables like age, sex, ASA grade, and the initial level of epidural attempt. In the result part, we observed that the first attempt success rate was higher in USG group, that is 70% versus the clinical group where it was 52% with a p-value of 0.1. There were no difference in number of passes, complication in between the two groups. The first attempt success rate was 18% higher in USG group compared to the clinical arm. The results were not significant statistically, as the study was powered by 31% difference between the two groups. Though the benefit of pre-scan in lumbar level has been studied before, there were limited studies evaluating the benefit of pre-scan in thoracic level. In our study, the blinded trainee anesthesiologist did not get any benefit of deciding the optimal angle of needed, and this resulted in a narrow benefit over clinical group. We recommend that the further studies would be needed to evaluate if pre-scan done by operator themselves would result in a better pass success rate. On the conclusion side, the ultrasound pre-scan to mark the upper border of lamina does have a higher success rate, 18%, than the conventional clinical method for epidural catheterization in mid-thoracic region by trainee anesthesiologist blinded to entire procedure. However, this result was not found to be statistically significant in the study, powered for a larger difference. I would like to thank my guide, Dr. Sumitra Bakshi and Dr. Madhvi Sheth Mahajan. Thank you.
Ma'am, you are not audible, ma'am.
Hello, Dr. Badal.
Yeah, yes, ma'am. Good morning.
Good morning. You said that pre-scan is better than the clinical method. How you did your study with the landmark guided? What was the landmark of your landmark of your palpating the lumbar spine and thoracic? How we palpate the spine?
Ma'am, we palpate the spinous process and in landmark.
At which level?
From
above down or down to up?
Ma'am, down to above.
Down to above.
Yes.
And at which level you put
we can also palpate from above to downward, but it depends upon it is from T5 to T2, so it is better to palpate from down to above.
Down to above. And at which level you put your put your catheter?
T5 to T8. T5 to T8, ma'am.
T8.
Yes,
Any complication at T5 to any cardiovascular complication you have seen in your study?
Cardiovascular complication has been found. There are some complications like dural tap in our study in both the group, but like in USGR and clinical also. Both are same.
And which type of surgery you included in your study? Which type of cancer patient you include? Which surgery?
Major abdominal surgery. I'm in CA pancreas and liver dissections, and in thoracic for the pneumonectomy patients.
Okay, thanks. Okay, thanks.
Now let's move on to the next research paper.
Greetings to all. Myself, Dr. Neha, Junior Resident from the Department of Anesthesiology and CCM from BRD Medical College, Gorakhpur. Today I am going to present my topic on to compare the airway assessment scoring of modified Mallampati versus Cormack-Lahani grading by video laryngoscope. A complete evaluation of airway with grading and knowledge of difficult airway can alert the anesthesiologist to predict the potential for difficulty with airway management and follow the appropriate planning. The aim of our study was to compare the modified Mallampati score with Cormack-Lahani scoring done by the video laryngoscope. The objective of our study was to find out the correlation of modified Mallampati scoring and with Cormack-Lahani scoring, and to see whether the preoperative airway assessment by modified Mallampati classification correlates with the Cormack-Lahani grading by video laryngoscope. Our study was prospective observational study. Patients admitted in BRD Medical College for elective procedures, they are assessed for eligibility, and written informed consent was taken from all the patients along with the permission of ethical committee. In inclusion criteria, ASA grade 1, grade 2, patient age between 18 to 65 years of age of either sex, patients posted for elective procedure from all the surgical specialties requiring endotracheal intubation. In the exclusion criteria, it was patient refusal, emergency surgical procedure, patient age less than 18 years and more than 65 years, pregnant patients, patient with unstable cervical spine, patient with tumor of larynx, patient with apparent restriction of mouth opening due to pain, patient with apparent restriction of neck movement. In our study, a total of 100 cases were taken. No patient was excluded from our study. In the pre-anesthetic checkup, airway was assessed by modified Mallampati score, Cormack-Lahani grading done using the video laryngoscope after giving sedatives and analgesics. In the statistical analysis, categorical data was summarized as in proportion and in percentages. Quantitative, that is discrete data, was summarized as in mean and in standard deviation. Statistical significance was kept at p less than 0.05. Program SPSS version 23 IBM Corporation was used for data analysis. In the result, we will see the correlation between the modified Mallampati classes and Cormack-Lahani grading. A maximum of 54 cases matched between class 1 grade 1, 8 cases for class 1 grade 2, 3 cases for class 1 grade 3, 0 case for class 1 grade 4. A maximum of 13 cases matched between class 2 grade 2, 6 cases for class 2 grade 1, 5 cases for class 2 grade 3, 1 case for class 2 grade 4. A maximum of 3 cases matched between class 3 grade 3, 0 case for class 3 grade 1, 3 cases for class 3 grade 2, 2 cases for class 3 grade 4. A maximum of 1 case matched between class 4 grade 4, 0 case for class 4 grade 1, 0 case for class 4 grade 2, 1 case for class 4 grade 3, 1 case for class 4 grade 4. The grade-wise distribution of correlation between the modified Mallampati score and Cormack-Lahani score showed MPS class 1 showed 83% correlation with CL grade 1. MPS class 2 showed 52% correlation with CL grade 2. MPS class 3 showed 37.5% correlation with CL grade 3. MPS class 4 showed 50% correlation with CL grade 4. The limitations of our study was the limited sample size, as the less number of cases were there for class 3 and class 4. In the conclusion, we have seen that the modified Mallampati scoring and Cormack and Lahani grading are good predictors for the tracheal intubation. A study showed that despite of video laryngoscopy done by the expert, the modified Mallampati classification did correlate with the Cormack and Lahani grading in lower grades, that is 83%, as compared to the higher grades, that is 37%. Thank you so much.
Hello, Dr. Neha. Hello. Hello, Dr. Neha.
I think she is not there. So we are moved to next.
No. Okay.
A very good morning to respected judges. I myself Dr. B.D. Balan from BRD Medical College, Gorakhpur. Title of my study: to study the efficacy of ultrasound guided vertebral nerve blocks in patients with trigeminal neuralgia receiving combination drug therapy. Trigeminal neuralgia is a sudden onset of intense stabbing pain which is paroxysmal in nature within the distribution of ophthalmic, maxillary, and mandibular branches of trigeminal nerve. The common trigger factors include chewing, speaking, brushing of teeth, exposure to wind, cold water, etc. Medical and surgical interventions are available, but standalone treatment is not satisfactory. Combination drug therapy along with the USG guided peripheral nerve block would provide satisfactory pain relief. Aim of the study to study the efficacy of ultrasound guided peripheral nerve blocks in patients with trigeminal neuralgia receiving combination drug therapy. The primary objective include to observe the patient reported pain score after peripheral nerve block in patients receiving free drug regimen using numerical rating scale. Secondary objective include to observe the satisfaction score of the patient and to observe any side effect of the drugs and any complication after giving peripheral nerve block. This is the illustration showing the division of a trigeminal nerve. Ophthalmic branch block, how to give. This is the diagram showing linear transducer placed in supraorbital notch over middle 1/3 of supraorbital margin. Needle introduced from lateral edge of targeting supraorbital notch and the drug is introduced. 2 ml of drug injected for the block. Maxillary and mandibular branch block is shown here. Curvilinear transducer placed below and palato-zygomatic arch in between condylar and coronal process of mandible. Lateral pterygoid plate also visualized by this one. By this approach, needle inserted anterior to lateral pterygoid for V2 block and posterior to lateral pterygoid plate for V3 block. 4 ml of drug is used for each. Materials and methods. Written informed consent was taken from all patients along with the permission of the ethical committee. All symptomatic patients based on the National Classification of Mental Disorder were included for the study. Exclusion criteria included patients with bilateral trigeminal neuralgia, secondary and hand having association with any other etiological factor. Patients who had received a radiofrequency ablation with other peripheral nerve blocks and surgical treatment within 6 months. Patients with uncontrolled systemic diseases, neuromuscular diseases, local infection, bleeding disorder, history of allergy or sensitivity to any of the study drugs. This is a prospective observational study. Total number of patients enrolled are 33. Patients excluded is number 0. Number of patients, 33 patients are given the 3 drug regimen and the drugs used were carbamazepine, amitriptyline and baclofen. After 2 weeks, the patients pain relieved and regimen continued are number 25 patients, and pain not relieved after 15 days. So the block given are given number of patients which are the block was given is number is 8. Patient followed up after 15 days is 8 and pain relieved after 15 days. And pain not relieved are when patient equivalence number is 0. And total patients analyzed of the end of the study is the same as beginning, number is 33. The following formula is used for the calculation of sample size. Descriptive statistics in the form of means or standard deviations. Medians are required for continuous variables, frequencies, and percentages for categorical variables. Statistical significance was kept at p-value less than 0.05 and program SPSS V23 was used for data analysis. This is the diagram showing observation results. Change in the first one is a change in NRS over time. The red block shows patients who received block and the blue shows patients who received 3 regimen only. All patients were given TDR, 3-drug regimen at the beginning of the study, and after 15 days, one group of people, this red group of people, were left without any significant result. So they were chosen for giving blocks, and after 15 days, they had an excellent pain relief. Next one is the satisfaction score of patients after therapy. After giving the 3-drug regimen, much of the blocks, and they had an excellent result, and there was no patients left without any significant pain relief. Drug therapy is the primary choice of treatment. Considering the side effects, patients can get immediate pain relief from minimally invasive peripheral nerve block. UST intervention allows precise targeting of the affected nerves without damage to nearby structures. The limitation study included UST guided block is user dependent. Possibility of inter-individual variations in the extent of block is there, always present. Conclusion: efficacy of combined drug therapy is reiterated and should be used as first line of therapy. USG guided peripheral, ultrasound guided peripheral nerve block improve patient report pain relief in patients who had higher pain scores even after receiving combination drug regimen therapy. USG provided a safe option for giving peripheral nerve blocks. We propose multi-modal therapy for pain relief. Thank you.
Hello, Dr. Balan. Hello. Hello, Dr. Hello.
Dr. Bini, are you there? Dr. Bini?
Hello.
Ma'am, seems like they are not here.
Okay, move to okay, move to next.
Okay.
Hello everyone, my name is Chaitra S and I'm from King George Medical University. I'm going to present a free paper on comparison of efficacy of dexmedetomidine and ketamine intravenous versus nebulization for awake fiber optic intubation. Coming to introduction. Fiber optic intubation is a standard technique in securing the airway in predicted difficult intubation scenarios. Since fiber optic intubation needs awake and cooperative patients, some sort of sedation and anxiety drug should be used. Hence, in this study, we have utilized dexmedetomidine and ketamine, known for their worldwide usage in fiber optic, and try to compare the efficacy between the combination of both the drugs given through intravenous and nebulization. The primary objective of the free paper was the time required for intubation between the group receiving dexmedetomidine and ketamine through intravenous versus nebulization. Along with the primary, we have compared whether secondary objectives like the sedation level, cough severity, patient tolerance, ease of intubation, hemodynamic changes during intubation, the recall of events during intubation in the post-operative period, and any adverse event that is associated with the intubation. The study setting, it was conducted in the Department of Anesthesiology, King George Medical University, after the written informed consent obtained by all the patient or the guardian. Study design is actually a randomized controlled double-blind study, which is conducted within 1 year period. Sample size, according to Mathur et al., 64 patients were required to have a 90% chance of detecting as significant at the file level a decrease in the time required for intubation between the two groups by dividing the 64 patients into 32 into each. The inclusion criteria includes the ASA physiologic state 1 and 2, the age between 18 and 60 years, patients giving written and informed consent. But the exclusion criteria includes any heart disease like AV block on electrocardiogram, heart failure, coronary heart disease, severe bradycardia, liver cirrhosis, thrombocytopenia, coagulopathies. Current psychiatric disorders like history of seizures are present, or any respiratory disorders, or history of epistaxis, nasal pathology, known drug allergy to the study drugs, or SA3 and 4 with the pregnant female. Coming to first, we have prepared the patient with adequate NPO along with the pre-anesthetic checkup. The patient was taken into the OT by routine monitoring devices such as ECG, heart rate, non-invasive blood pressure monitoring, and oxygen saturation were attached and record. 2 drops of vasoconstrictor, that is xylometazoline 0.1% was introduced into both of the nostrils. Injection glycopyrrolate 0.2 mg IV and ondansetron 4 mg IV was given as pre-medication. In randomization, it was divided into 2 groups, Group I and Group N. Group I received dexmedetomidine 1 mg per kg, 1 microgram per kg, and ketamine 0.5 mg per kg through intravenous route in 20 ml syringe with nebulization with 5 ml of NS over 10 minutes. Where Group N, that is receiving dexmedetomidine 1 microgram per kg and ketamine 0.5 mg per kg through nebulization route with a normal intravenous saline, that is 20 ml through over 10 minutes. Where coming to assessment, we have assessed the modified sedation, modified assessment of alertness or sedation score, which if it's equal or less than 3, we are attempting the awake nasal fiber optic intubation. If it is more than 3, injection propofol was given, and the dose that is required to bring the sedation of score 3 was noted. And now coming to the procedure, while doing the procedure, the ease of intubation, the intubation time, that is the passing the flexible fibro bronchoscope tip through the nostril to the first reading obtained by the capnography, where you have the patient tolerance was noted, and later the patient was induced with fentanyl, propofol, and vecuronium. Coming to postoperative period, in the postoperative period, the level of recall of fibroscopy by the patient and the discomfort during the procedure and any adverse event that is associated with them was asked by the patients. In the results, the primary outcome was the time, the mean time for intubation, which was found less in Group I compared to the Group N, which in Group I it was 49.19 seconds, in Group N it was 75.69 plus or minus 10.83 seconds, with a p-value of less than 0.001. But between the group, between comparing the OAAS score, the Group I was found better than that Group N with before the propofol given with a p-value of less than 0.001. Then other scores like facial grimace score between the 2 groups, it was found better in the Group I with a p-value less than 0.001, and a cough severity was also found better in the Group I compared to Group N with a p-value less than 0.001, and the ease of intubation was also better in Group I compared to Group N with a p-value equal to 0.001. The hemodynamic variables, the heart rate, systolic blood pressure, diastolic blood pressure, mean blood pressure were all decreasing trend in Group 1, and they were statistically significant between Group 1 compared to the Group N after the 6 minutes. Majority of the patients of Group I, that is 68.8%, and Group 2, 81.3%, did not have any discomfort during the procedure. None of the patients of Group I and 12.5% of the Group 2 patients had moderate level of discomfort and rest. Rest had mild and partial discomfort. So difference between the level of discomfort between the 2 groups was not statistically significant. Coming to discussion, in our study, there was no failure of intubation in either group. Gupta et al. Reported a mean intubation time of 200.4 seconds in the nebulization group, where Shakal et al. Reported a mean duration of 58.9 plus or minus 6.1 seconds for a combination of dexmedetomidine and ketamine given through the intravenous route. But in our study, we found that the time required for the intubation was significantly less in Group I compared to that of the Group N with a p-value of less than 0.001. The cough severity was less in Group I compared to the Group N because during nebulization, unpredictable deposition of the drug can lead to patchy, less effective anesthesia. Gupta et al. Observed significant coughing in the nebulization group. Dexmedetomidine being an alpha-2 agonist acts on locus coeruleus involved in the physiological response of stress and anxiety, which is a principal site for norepinephrine synthesis. Literature supports the tropical effect of ketamine via its NMDA antagonist with a primary site of action in the CNS and parts of the limbic system based on the animal mode. The facial grimace were better in Group I compared to that of the Group N during the intubation. Coming to conclusion, in our study, we conclude that dexmedetomidine is a useful agent for awake fiber optic intubation, allowing good sedation, and adding ketamine further enhances the hemodynamic stability because of the opposite action on the cardiovascular system. Thus, we conclude that the efficacy of dexmedetomidine and ketamine through intravenous is better than the nebulization for achieving better intubating conditions and hemodynamic variables. Thank you.
Hello. Hello.
Hello, good morning, ma'am.
Good morning. Any patient in your study required intratracheal local anesthetics, or no patient is?
No, ma'am. As such, we actually we had given blocks to all the patients. That is the supralaryngeal block and the transtracheal. But as such, we didn't use any in-spray technique of local anesthetics, ma'am.
Whenever you give the propofol to the patient,
Yes,
before placing the fiber optic in nostrils, or after it goes to the vocal cords?
Ma'am, actually in our study, we needed an observation sedation score of less than 3. In nebulization group, we usually found it was around 4 and 5 itself. So we had to give propofol for them to get the score to 3, ma'am. So it was like mild sedation propofol dose was used, like 0.2 to 0.7 we used. So around 20-30 ml, they just came to group like level 3, where you just on little probing, they were responding. So then we proceeded to fiber optic.
And you fall in oxygen saturation?
Ma'am, in nebulization group, there was a fall in oxygenation, but the minimum it went up to 96, but not more than that. Like severe oxygenation where you had to disabandon the procedure. Nothing was observed, ma'am.
Okay, thank you. Thank you,
Thank you,
Dr.
ma'am.
Chitra.
Thank you.
Hello, Doctor. Hello, Renisha. Move to next, please.
So now we move on our next session.
Good afternoon. I'll be presenting my study, which is a double-blind randomized control study comparing the effectiveness of hemocoagulus versus tranexamic acid in reducing perioperative blood loss in major orthopedic lower limb surgeries. Major orthopedic surgeries are commonly associated with excessive perioperative blood loss, and strategies such as hypotensive anesthesia and drugs like ethamsalate, aprotinine, tranexamic acid, and hemocoagulase have been used to reduce or control the perioperative blood loss. Tranexamic acid exerts its antifibrinolytic effect through reversible blockade of lysine binding sites and plasminogen molecules, reducing the conversion of plasminogen to plasmin, and hence prevents fibrinolysis and decreases blood loss. Hemocoagulase is an anti-hemorrhagic enzyme complex that is present in the venom of Bothrops gerareca or Atrops snake. It acts as a thrombin-like enzyme converting fibrinogen to fibrin, thus promoting and stabilizing the clot formation. The prerequisite for it to to promote the clot formation is the release of platelet factor 3 by injured vascular endothelium, as it acts only at the surgical site and avoids widespread intravascular coagulation. However, there are few studies comparing the effectiveness of both these drugs in orthopedic surgeries. So we designed a prospective randomized trial to evaluate and compare the effectiveness of hemocoagulase and tranexamic acid in reducing the perioperative blood loss in orthopedic lower limb surgeries. So the aim of our study was to compare the effectiveness of hemocoagulase and tranexamic acid in reducing perioperative blood loss in major orthopedic lower limb surgeries under neuraxial anesthesia. The primary objective was to compare the amount of blood loss in the perioperative period as well as the need of blood transfusion in the perioperative period between the two groups. The secondary objective was to compare the coagulation indices pre and post-operatively by comparing the PT, INR, and APTT values. The sample size was estimated by using the difference in mean blood loss in a study that was done by Ankit and Deepesh Gupta in August 2019. Using this formula, we obtained a sample size of 60 cases in each group. After institutional ethical committee approval, we included patients belonging to ASA physical status 1 and 2, age between 18 to 75 years of either sex, who gave informed valid consent, undergoing elective lower limb orthopedic surgeries under regional anesthesia. We excluded the patients with a history of DVT and thromboembolic drugs or study drugs, as well as pregnant and lactating females. The group T, comprising of 60 patients, received tranexamic acid 10 mg per kg IV 15 minutes prior to the incision, followed by an infusion of 1 mg per kg per hour till the end of surgery. The group H patients received hemocoagulase 1 mg and coagulation profile pre and post operatively. The total amount of blood loss was calculated by measuring the amount in the suction jar surgical site spillage, as well as weighing the blood soaked sponges, swabs, and surgical drapes. The blood present in the brain at 24 hours was also included in the total blood loss. The total duration of surgery, as well as the number of units of whole blood and PRBC transfused in the perioperative period, were also noted. The criteria for transfusion was hypotension due to hemorrhage, blood loss more than 20% of the patient's blood volume, or fall in hemoglobin below 8 grams deciliter. The data analyzed was significant. So total blood group for 28.4 ml, 7 statistics. The group the reduction in hemoglobin in the group H, 8.3% of the patients in the intraoperative received blood transfusion, and post-operatively in group T, 46.7% of the patients and 40% of the patients in group H received post-op blood transfusion. However, this difference was not statistically significant. When we compared the PT, INR as well as the APTT, the difference was not statistically significant, with reduction in the prothrombin time in group T being 0.76, in group H it was 0.71. Reduction in INR in group T was 0.05, in group H it was 0.06. Reduction in APTT was 0.42 and 0.54 in group H. Both group T and H had comparable demographics in terms of age, sex, BMI, and duration of surgery. The total perioperative blood loss percentage reduction in hemoglobin and hematocrit values, both pre and post-operatively, was similar in both the groups. In a study in 2019 by Singh A and Gupta D, showed significantly increased blood loss in the tranexamic group compared to the hemocoagulase group. However, the percentage reduction in hemoglobin and hematocrit values was similar in both the groups. In our study, we found that both the groups had similar blood requirements in the perioperative period. Zhu Wu A et al. In their study had similar results. They showed that hemocoagulase and tranexamic acid mitigated blood transfusion requirements equally when compared to the control group. In our study, we observed no significant changes in the pre and the post-op values of PT, INR, and APTT. U.M. Shen L et al. Also reported no statistically significant difference in the coagulation indices in the pre versus post-op values on day 1 and 3. It is when they compared the hemocoagulase versus the placebo group. Singh A et al. Also reported no change in the coagulation profile in patients who received tranexamic in the tranexamic group versus the hemocoagulase group in patients undergoing orthopedic hip surgeries. So we concluded that both tranexamic acid and hemocoagulase are equally efficacious in reducing perioperative blood loss and transfusion requirements in lower limb orthopedic surgeries. We observed no change in the coagulation profile in pre-op and post-op values in my references. Thank you.
Hello, Dr. Fareen. Hello, Dr.
Yes, good morning, ma'am.
Good morning.
Good morning, ma'am.
Good morning.
Morning, ma'am.
Any control in your study? You have a control group or only the H and T group?
No, ma'am, we didn't have a control group. We had only an H group and T group. Yes, ma'am.
Okay.
Sorry,
Then
ma'am.
how can you decide that the perioperative requirement of blood is less in both the group?
Ma'am, actually, that is the limitation of our study, ma'am.
Okay.
Because there are studies which are comparing control group versus Tranexa or control versus hemocoagulase. But there are very few studies in literature comparing only these drugs, ma'am. So our aim was to study only these two drugs, like comparison between these two, ma'am.
And preoperative hemoglobin or hematocrit level in both the groups are same or different? There is too much difference in hemoglobin, percentage of hemoglobin and hematocrits were in both the groups. What was the baseline level? What was the baseline level of your hematocrits and hemoglobin? Baseline preoperative level.
Ma'am, more than 10, ma'am. We had
in both the groups.
Yes, ma'am. Both the groups. Yes, ma'am. It was similar in both the groups, ma'am.
Okay, okay. Thanks, Dr. Farid. Thanks. Thank you so much.
Thank you, ma'am.
Renisha, move to next.
So now we move on the next session.
Today, I'd like to present my paper to determine the efficacy of oral aprepitant for prevention of postoperative nausea and vomiting in adult patients undergoing laparoscopic surgeries. Post-op nausea vomiting, or PONV, is defined as nausea or vomiting occurring within 24 hours of surgery. PONV is a common complication following surgery occurring in up to 80% of patients without antiemetic prophylaxis. Even among patients who do receive antiemetic prophylaxis, they do not produce complete protection. Hence, there is still a need for more effective therapy to prevent PONV. Aprepitant is a highly selective brain-penetrant NK1 receptor antagonist with a long and it has been demonstrated as a superior agent for PONV prophylaxis used as a single agent in patients undergoing open abdominal surgeries, craniotomies, breast and thyroid surgeries. However, there is no anesthesia with inhalational anesthetic agents. The aim of the study was to determine the efficacy of oral aprepitant for prevention of postoperative nausea and vomiting in patients undergoing laparoscopic surgeries. Primary objective is to assess the severity of nausea and vomiting using verbal rating scale and grade of PONV. Secondary objectives are to determine the number of episodes of vomiting and requirement of antiemetics postoperatively, and to determine the safety profile of aprepitant as part of antiemetic prophylaxis. This is a prospective randomized double-blinded control study conducted in the Department of Anesthesiology in JSS Hospital, Mysore. 120 patients were categorized into ASAPS class 1 and 2, aged 18 to 60, undergoing laparoscopic surgeries who fulfilled the inclusion criteria. Computer-generated randomization was done, and participant and investigators were blinded. The sampling technique used was simple random sampling. This was determined by a previous study by Jaibalan et al. The required sample size to show a difference in the proportion of postoperative vomiting between aprepitant and ondansetron was found to be 60 in each arm. Inclusion criteria: age 18 to 60 years of both genders, ASAPS 1 and 2, and undergoing laparoscopic surgeries under general anesthesia. Exclusion criteria: patients on treatment with antiemetics or steroid medication or other drugs known to cause emesis. Patients with known hypersensitivity to ondansetron or aprepitant, pregnant or nursing mothers, hepatic or renal insufficiency, vomiting within 24 hours before surgery or any other organic etiology, and surgery more than 2 hours in duration. All patients planned to undergo laparoscopic surgeries were randomized into two groups. Group A, the aprepitant group, who received tablet aprepitant 80 mg 2 hours prior to the surgery, and a placebo IV antiemetic as part of the premedication. Group B, ondansetron group, who received an oral placebo 2 hours prior to the proposed surgery and injection ondansetron 4 mg IV as part of premedication. All these patients underwent routine general anesthesia as per institutional protocol. Incidence and severity of postoperative nausea vomiting were noted every second hourly for the first 6 hours, and thereafter every 6th hourly up to 24 hours. Severity and grading of PONV using VRS scale was documented. Incidence of retching was also noted, and injection ondansetron 4 mg as rescue antiemetic was used for episodes of severe nausea, retching, and vomiting. Statistical analysis. The data was analyzed using SPSS 21 software. The descriptive statistics was determined by mean plus or minus standard deviation and percentage. Inferential statistics for continuous variables using independent t-test and ANOVA. Qualitative data using chi-square test. This is my consort diagram where both groups had 60 patients who completed the study. Results, demographics. Both groups were comparable in respect to age and gender. VRS for nausea was statistically significant after 2 hours postoperatively, where Group A had a higher mean for VRS score at 1.12, whereas Group B had a score of 0.35. It is observed that grade of PONV from immediate postoperative period till 24 hours was not statistically significant amongst these groups, though more patients in Group A had grade 2 PONV at 2 hours postoperatively compared to Group B. It was observed that the rescue antiemetic usage was similar amongst both groups in the immediate postoperative period, but was higher in Group A at 2 hours postoperatively than in Group B. This was clinically significant, however, it was not statistically significant. Recently, oral aprepitant has garnered a lot of attention as an antiemetic compared to ondansetron with better efficacy and longer duration of action as observed in previous studies done by Jaibalan et al. And Diamond et al. This study was designed to determine the efficacy of aprepitant in prevention of PONV. We chose to compare it with IV ondansetron as this was a standard antiemetic in our institution. Our findings differ from earlier studies where Diamond et al. Studied 922 patients undergoing open abdominal surgeries and found oral aprepitant to be more effective than IV ondansetron. This was supported by Gan et al. However, in our study, we found that patients receiving ondansetron had lesser incidence and lower scores of VRS for nausea compared to patients receiving aprepitant at 2 hours postoperatively, but comparable from 4th hour to 24 hours postoperatively. Similarly, the increased use of rescue antibiotics in aprepitant in the immediate postoperative period to 2 hours post-op. Results showing better outcomes in ondansetron group compared to aprepitant group could be due to the patients undergoing laparoscopic surgery, where the mechanism of action of ondansetron worked in favor of these patients in prevention of PONV. Neurotransmitter receptor systems involved in transmission of impulses causing nausea and vomiting include cholinergic, dopaminergic, serotonergic, histaminergic, and NK1 systems. Targeting one particular receptor may not confer complete protection against PONV. Thus, inclusion of aprepitant to multimodal PONV prophylaxis may have positive attributes of long half-life, innocuous effects of QT prolongation, and effective prevention of PONV. Both aprepitant and IV ondansetron are effective in decreasing the severity of PONV. Ondansetron had produced lower nausea severity and decreased use of rescue antiemetics compared to aprepitant in the immediate postoperative period. However, the further research is warranted to determine the optimal dose of aprepitant in PONV prophylaxis and treatment, rescue schemes, interaction with other antiemetics, as well as cost effectiveness. These are my references. Thank you.
Hello, Dr. Gautam.
Good morning, ma'am. Yes.
Good morning. What was the exclusion criteria in your study? What are the exclusion criteria?
Ma'am, yes, ma'am. Ma'am, we excluded all patients above ASA class 2, ma'am. So ASA, PS class 3 and 4. Also, patients who drugs which could cause or which was used as a, so that as a confounding factor could be eliminated.
And what was the incidence of nausea and vomiting on ondansetron group?
Ma'am, the total incidence in ondansetron group was 30%, ma'am.
And in aprepitant?
And in the aprepitant, it was 36%, ma'am.
Okay. And
yes.
You observed your patient only for 24 hours, no?
For up to 24 hours after shifting to the
Okay. And
yes.
What was the onset and duration of action of aprepitant drug?
Yes, ma'am. Ma'am, onset of action is 4 hours after giving the drug orally, ma'am. And duration is up to 18 hours, ma'am.
Okay. Okay. Thanks, Dr. Gautam. Thank you.
Yes.
Now we move on our next session.
Hello everyone, myself Dr. Niveta. My title for e-research paper is Comparative Study of Facial Iliaca Compartment Block and 3-in-1 Nerve Block for Postoperative Analgesia after Hip Hemiarthroplasty. Introduction. Pain after hip hemiarthroplasty surgery may potentially hinder postoperative physiotherapy and early mobilization. Digital anesthesia of the lower limb appears to be effective for postoperative pain control in this setting, and it has been shown that the lumbar plexus blockade provide high-quality analgesia as the femoral nerve supplies the anterior hip joint capsule as well as the proximal femur, the quadriceps, iliacus, and the pectineus muscle. A prospective study demonstrated that 3-in-1 nerve block could achieve a success rate of 81% block of the femoral nerve 96% of lateral femoral cutaneous nerve, and 4% of the obturator nerve. These three nerves can also be blocked together by fascia iliaca compartment block because the fascia iliaca compartment contains these nerves within the potential space. Aim and objective: to compare the analgesic efficacy of USG guided fascia iliaca compartment block and 3-in-1 nerve block after hemiarthroplasty, to assess the duration of analgesia, to assess the additional analgesic requirement, to assess the incidence of any adverse effect. Study design: it is a prospective, randomized, and controlled study. Material and method: after getting approval from Institutional Ethics Committee, the study was conducted in the Department of Anesthesiology, Shamsha Medical College and Associated Hospital, Rewa, Madhya Pradesh, from January 2020 to December 2020 on 90 patients posted for hip hemiarthroplasty under subarachnoid block. Inclusion criteria: patient age 50 to 75 years, of either sex, undergoing hip hemiarthroplasty of ASA grade 1 and 2. Exclusion criteria: significant disease like asthma, diabetes, hypertension, and cardiovascular disease, patient refusal, allergic to local anesthetic, infection over injection site, coagulopathy, psychological disorder like mental illness and dementia. Patient fulfilling the selection criteria were randomized using a computer-based randomization software in 3 groups of each depending on the block given. Group 1 received USG guided fascia iliaca compartment block with 30 ml of 0.25% ropivacaine at the end of the surgery. Group 2 received USG guided 3-in-1 nerve block with 30 ml of 0.25% ropivacaine at the end of the surgery. Group C control not receive either of the blocks. A detailed history of all selected patient was taken. A thorough pre-anesthetic evaluation, including the airway, back of the patient, and site of the block was performed. Patients were explained about the entire procedure. Informed consent and video consent were taken. They were educated about the visual analog scale. Thereafter, they were shifted to the operation theater. Intravenous line was secured. Mortar were attached, and baseline parameter was heart rate, systolic and diastolic blood pressure, mean outlet blood pressure, SpO2, ECG tracing were recorded. Subarachnoid block with injection bupivacaine 0.5% heavy, 2.5 ml at L3, L4 interspinous phase via 25 gauge Winky spinal needle in sitting position was given to all patients. Standard hemodynamic monitoring was done. Fascia iliaca compartment block or 3-in-1 nerve block was performed under real-time USG guidance with high frequency ultrasound probe, mind rate DC30 at the end of the surgery in group 1 and group 2 respectively. Group FICB. The goal was to place the needle tip under the fascia iliaca, approximately at the lateral third of the line, connecting anterior superior iliac spine to the pubic tubercle. It is our fascia iliaca. It shows the infiltration of local anesthetic. It is our fascia iliaca. It shows the infiltration of local anesthetic under the fascia iliaca under the iliopsoas muscle. Group 2, 3-in-1 femoral nerve block. In 3-in-1 nerve block, we have to infiltrate the local anesthetic just near to femoral nerve. After completion of the surgical procedure and block, the patient were transferred to post-operative anesthesia care unit. Pain severity was assessed using a visual analog scale, which was recorded at 0, 2, 4, 6, 8, 12, 18, 20, and 24 hours after block. When VAS score equal to or more than 4 or the patient first demand for analgesia, injection tramadol 100 mg IV was given as rescue analgesic. The duration of the analgesia and the total tramadol consumption in the first 24 hours were noted. Patient satisfaction score was assessed using a 5-point scale. It says highly satisfied, satisfied, neither satisfied, not dissatisfied, dissatisfied, highly dissatisfied. The study was completed 24 hours after block placement. Statistical analysis: all the measurement data were presented as mean plus or minus standard deviation, and statistical processing was performed using SPSS software. The categorical data analyzed by using chi-square test, while the quantitative data by one-way ANOVA and student t-test. The data with the p-value less than 0.5 was considered as statistically significant. Results: demographic parameter. In our study, all 3 groups have similar demographic parameter, and the duration of surgery difference between these 3 groups were statistically comparable with p-value more than 0.05. VAS score: the mean VAS score was higher in control group compared to the study group, which was statistically significant with the p-value less than 0.05, and also among the study group, FICB has low VAS score compared to 3-in-1 femoral nerve block, which has significant p-value less than 0.05. Duration of analgesia: the time to first rescue analgesia was higher in fascia iliaca compartment block. It is about 11 plus or minus 3 hours, and in group 3-in-1 femoral nerve block, it is about 10 plus or minus 3 hours. Compared to control group, it's about 4 plus or minus 1 hour, which are statistically significant with the p-value less than 0.05. Compared to 3-in-1 femoral nerve block, FSCB group has longer duration of analgesia and has statistically significant p-value. Total tramadol requirement in first 24 hours. It is about 123 milligram in FICB and 140 milligram in group 3-in-1 femoral nerve block. Compared to control group, it's about 226 milligram, which was statistically significant with p-value less than 0.05. Patient satisfaction score among the patients in group FICB 56.7%, and in group 3-in-1 femoral nerve block 36.7% were highly satisfied, whereas patient in control group none of them were highly satisfied, which is statistically significant. Adverse effect, no adverse effects found other than nausea and vomiting, which is also treated with ondansetron. Similar results were found by LT Gerald et al. 2012, Pandya and Jawar et al. 2014, Shukla et al. And 2018. Summary and conclusion: because of the aging of the population, the number of elderly patients accepting the hip surgery were increasing by the year. Regional anesthesia can not only decrease the stress response caused by surgery and pain, but can also shorten hospital stay, reduce medical bills, and allow early post-operative rehabilitation. Peripheral nerve block using local anesthetic allow the patient to avoid the adverse effect of opiate analgesic, reduce the risk of post-operative chronic pain. With the low concentration of local anesthetic for post-operative analgesia, it is possible to selectively block the sensory nerve fibers. Preservation of motor function promotes early rehabilitation and decreases the risk of deep venous thrombosis. Peripheral nerve block is also less likely to cause post-operative cognitive dysfunction, less intraoperative blood loss, and improve blood circulation, reduce the incidence of post-operative delirium, complex regional pain syndrome, and cardiovascular complication. So we concluded that FICV and 3-in-1 nerve block recommended for post-operative analgesia after hemiarthroplasty, while FICV technique better in terms of high degree of sensory blockade of LFC nerve and improve analgesia when continuous passive motion is initiated in the early post-operative period. FICV is easy to perform, reliable, and does not threaten any vital organ. These are my references. Thank you.
Hello, Dr. Nivedita.
Hello, good morning, ma'am.
Good morning. Your patient under spinal anesthesia?
Yes, ma'am. Spinal
all the
anesthesia,
surgeries are
ma'am.
performed under spinal anesthesia?
Yes, ma'am. Spinal anesthesia, ma'am.
And then what was the endpoint of your, how can you assess that after spinal anesthesia, how much time the patient take for rescue analgesia?
Ji, ma'am. Ma'am, actually, it is a limitation of the study because till the spinal effect regress to T12.
You note the spinal effect of spinal anesthesia? You have noted?
Ji, ma'am. Yes, ma'am. And I also follow the patient till 24 hours. So the limitation of the study is the onset of the sensory blockade is a limitation, ma'am.
And you performed fascia iliaca and 3-in-1 block after the surgery?
Yes, ma'am. End of the surgery, ma'am.
Then the surgeon have no objection for that the sterilized area or you are performing block. Why you can't perform before in preoperative period?
Ma'am, for my study is to give post-operative analgesia, ma'am. My aim is to give post-operative analgesia.
Many of the surgeries are performed giving the perioperative preoperative block for post-operative analgesia. Most of the time we perform block in preoperative area before the operation.
Ji.
Okay, thanks, Dr. Nathan.
Ji, ma'am. Thank you, ma'am.
Hello, Ranisha. Any complication you have seen with fascia iliaca block?
No, ma'am. No, ma'am. Actually, it is far away from vascular structure and neural structure, and anatomy is easy. And I am using USG guided for better anatomy and accuracy. So no side effects. I able to find, ma'am. No side effects.
And in 3-in block, you found any patchy analgesia? Yeah.
Yes, ma'am. In a few patients, the sparing of operator nerve is present, medial sensory nerve.
Then these have effect on your statics. There is
no, ma'am. Insignificant value, ma'am. Comparatively low, insignificant values.
Okay.
Thank you, ma'am.
Ranisha. Hello, Renisha.
Ma'am, this
Yes, move to
presentation.
next.
Last presentation. Hello, ma'am, am I audible?
Yes, yes, you are audible.
Ma'am, it was the last presentation.
Okay, okay, okay. Thanks. Thank you so much. लीव कर दें क्या मीटिंग को? ये कुछ नहीं करेंगे क्या? मीटिंग खत्म तो लीव आ गया ना, तो लीव कर देते हैं, अपन लीव कर देते हैं। हमने तो पहले ही 10 मिनट पहले खत्म कर दिया ना।
Can I hear the voice of
Good morning. Good morning. Shall we start the session? Yeah, sure. Yeah, the three of the lecturers, Sir Dr. Mangal, Dr. Dev Vijay, and Dr. Aurora, sir, are here, sir. Dr. Gilcha. Yeah. Are here.
Just a moment, Dr. Aurora.
Yeah.
Here is Dr. K.K. Arora. He is and head of the MGM Medical College Indore. He is experienced experience in obstetrics and anesthesia pain. He is awarded by
Welcome, Dr. Aurora. We shall start with the lecture, sir. And Simran, can you please put the first introductory slide of our speaker? Dr. Aurora, please introduce the speaker. Thank you. Yeah. I see. The first speaker of this session
is Dr. Girja Prasad Rath. Is Professor Neuroanesthesia and Critical Care at AIMS, New Delhi. Is Executive Editor of Journal Neuroanesthesia and Critical Care and Director at Large of SNSCC USA. His area of interest is neuromonitoring, awake neurosurgery, and pediatric neuroanesthesia. He is honored with the ICMR International Fellowship, Fellow of Indian College of Anesthesiologists, and Fellow of International Medical Science. To his credit, there are more than 250 papers and more than 25 chapters and edited 2 books. He is invited speakers of various national and international conferences. So, I would request Dr. Girja Prasad Rath to deliver his lecture. Dr. Girja Prasad Rath, please.
Yeah, Simran, please.
Yeah.
A very good morning to all of you. I will be talking about a clinical approach to diagnosis of brain death and optimization of organ donors. I have no disclosure for this presentation. Before I discuss about this vast topic as such, I will just mention about the rationality behind carrying out brain death diagnosis. Actually, the transplant program requires donation of healthy peripheral organs. Therefore, early diagnosis of brain death before systemic circulation fails is required. That helps in allowing salvage of different organs. Moreover, the modern medicine usually keeps a body functioning normal over an extended period of time. And we don't have critical care facilities, which is quite vast and inexpensive. And these critical care facilities usually drain on other medical resources, and ICUs, as we know, should not be overloaded with patients who can never recover from the cerebral function. Now, how this brain death determination is carried out? It is carried out in 4 steps. First step is clinical evaluation of the patient after the patient meets with the all prerequisites of brain death determination. Second is neurological assessments, which is carried out in 2 phases, 2 examinations, 6 hours apart, and sometimes ancillary tests are utilized. However, it is not properly defined in our country. And the 4th one is documentation of time of brain death. Now coming to clinical evaluation. The first step is to establish the irreversible and proximate cause of coma. For that, we need to know the history of the patient, different clinical examinations, laboratory tests, neuroimaging evidences of an acute CNS catastrophe that is compatible with clinical diagnosis of brain death. Now, at that point of time, one has to exclude the potentially reversible causes. For example, drug intoxication. There are certain CNS depressant drugs the patient might be taking. Poisoning due to injection of different sedatives and paralytics. So all these conditions will mimic brain death. That has to be excluded. The patient might be having severe electrolyte and acid-base imbalances, endocrine and hemodynamic disturbances. That has to be settled before clinical means brain death diagnosis process starts. And the other prerequisites include, which are very important, normal core body temperature and normal blood pressure. Now, for neurological examination, there are three cardinal signs which are important. First is coma, second is absence of brainstem reflexes, and the third is complete cessation of spontaneous respiration or carrying out apnea test. I will just touch upon few of these aspects. First, coming to coma, we all know it is unresponsiveness. That means with a noxious stimuli, there is absence of any response, although the spinal reflexes may be present in these patients. Absence of brainstem reflexes, it is done by carrying out different reflex tests like pupillary light reflex test, corneal reflex, pharyngeal or gag reflex test, tracheal or cough reflex test, oculocephalic or doll's eye reflex, uh, oculovestibular or cold caloric test, facial grimacing to noxious stimuli. So all these reflex tests will suggest about various cranial nerve function. Now coming to apnea test. This test also requires different prerequisites. For example, the patient will have to have everything normal like normothermia, normotension, euvolemia, no electrolyte or acid-base imbalance, normoxia, eucapnia, normal pH, etc. Now, how it is carried out? First, the patient is pre-oxygenated for 10 minutes with 100% oxygen. Then the uh, um, ventilatory frequency is reduced to eucapnia. PEEP is also reduced. If the SpO2 remains more than 95%, then at that point of time, take a baseline ABG. Then disconnect the patient from the ventilator, but preserve the oxygenation process by placing an insufflation catheter through the endotracheal tube close to the carina and deliver 100% oxygen at 6 to 8 liters per minute. Then look for respiratory movements for 8 to 10 minutes. Now, at this point of time, if there is hypotension with systolic blood pressure less than 90, or hypoxia with SpO2 less than 85%, or there is arrhythmias, then abort the test, and that can be repeated after some time. But if there is respiratory movements observed, that indicates negative apnea test. That means it doesn't support the diagnosis of brain death. If there is no respiratory movement, then ABG has to be repeated. If the PaCO2 is more than 60 or PaCO2 is more than 20 millimeter of mercury over the baseline values, that indicates positive apnea test, and it supports the diagnosis of brain death. If the test is inconclusive, but the patient is hemodynamically stable, then it can be repeated for a longer period of time after the patient is again adequately pre-oxygenated. Now, there are two clinicians who usually do this brain death certification. In absence of a neurologist or a neurosurgeon, and surgeon or physician and an anesthetist or intensivist usually perform these tests. That follows documentation of brain death. Actually, the time is noted when the time for arterial PaCO2 reaching the target value is achieved, that is the time of death. And that may require subsequently, at some point of time, the confirmatory tests or ancillary tests are required. As I mentioned earlier, it is not properly defined in our country. These confirmatory tests are not mandatory, but desirable in specific situations when components of clinical testing cannot be reliably performed. So brain death diagnosis, again to re-emphasize that it is a clinical diagnosis and ancillary tests cannot replace them. Moreover, these ancillary tests actually requires a lot of expertise. They may be angiography, EEG, nuclear scanning, transcranial Doppler, CT angio, or MRI angio. And there are many more discussed. I will just mention about transcranial Doppler, not in detail I'm discussing. You may be getting a reverberating flow pattern because in most of the ICUs nowadays, this transcranial Doppler is present. I would suggest to carry out this transcranial Doppler to further confirm brain death. Now, optimization of organ donors. This is required because there is an increased discard rate of transplanted organs, and it ranges from in kidney around 15% to heart and lung around 60%, and it is even higher in other organs. What is the reason? It may be because of poor donor organ quality. So why it is poor? Because the brain death process, when it starts, there is a lot of pathophysiological changes that may occur. It may range from cardiovascular changes, pulmonary, endocrine, and metabolic changes to temperature dysregulation, coagulation abnormalities, and inflammatory and immunological changes. I'm going to discuss each one of them one by one. First, coming to the cardiovascular changes. Usually these patients, they come with severe rise in ICP, hence there is coning or herniation of the brain. That will cause cerebral ischemia, and this ischemia will lead to vagal stimulation as a last-ditch effort to counter this ischemia. So there is bradycardia and hypotension. But this ischemic episode doesn't stop there. It progresses rostropodally. So when it reaches the pons, there is already vagal stimulation and sympathetic stimulation is added here. So vagal stimulation causes bradycardia and sympathetic stimulation causes hypertension, which is famously known as Cushing's response. Now this ischemic episode, when it reaches the lower end of medulla, there is vagal cardiomotor nucleus. So this function of this motor nucleus is now lost. So there is no vagal stimulation, only unopposed sympathetic stimulation is there. So there is severe in tachycardia, hypertension, and increase in cardiac output, and increase in systemic vascular resistance. This is known as autonomic, sympathetic, or catecholamine storm because the catecholamine levels are raised by several folds. Then this ischemia will progress to the spinal cord, which will cause sympathetic inhibition. So there is no vagal stimulation, and now there is sympathetic inhibition. That will lead to bradycardia, hypotension, decreased cardiac output, decreased systemic vascular resistance, and finally cardiovascular collapse or cardiac arrest. Now, pulmonary changes. Some of them, they are unrelated to brain death. As such, the patient might be associated with it, like aspiration and pneumonia, etc. And sometimes there is brain death related injuries like inflammatory acute lung injury or neurogenic pulmonary edema. This neurogenic pulmonary edema may occur because of this sympathetic storm leading to increase in systemic vascular resistance, and there are many more processes leading to neurogenic pulmonary edema. Now, what are the endocrine and metabolic effects? There is progressive failure of hypothalamo-pituitary axis in brain dead patients. Most commonly, the posterior pituitary is affected. So there is loss of ADH secretion. So invariably, these patients will present with diabetes insipidus, presenting with polyuria, dehydration, and different metabolic derangements like hypernatremia, hypokalemia, hypocalcemia, and hypomagnesemia, etc. The anterior pituitary may be affected, so that will cause decrease in thyroid hormones, particularly T3. When T3 is reduced, there is progressive loss of cardiac contractility, decreased metabolism, increased anaerobic metabolism, hence lactic acidosis, which will further compromise the cardiac contractility. There may be decreased plasma cortisol due to hypoadrenalism and impaired donor stress response that will cause further cardiovascular collapse. The insulin may be reduced, that is secondary to decrease in stress response and insulin resistance. So these patients of brain death will present with hyperglycemia. Now, temperature dysregulation may occur because of loss of hypothalamic function, and there may be also hypothermia, which is aggravated by loss of vasomotor tone and fall in metabolic rate. But if the core temperature is less than 32 degrees centigrade, there may be other complications like dysrhythmia and coagulopathies. As such, these coagulation abnormalities may be present in more than 30% of patients with isolated head injury, which are the usual brain dead organ donors. And this is because there is thromboplastin release from the necrotic brain tissue, which activates both coagulation cascades, extrinsic and intrinsic. There may be also dilutional coagulopathy associated because of initial large volume resuscitation in these patients and massive blood transfusion. And there may be PIC, uncontrolled bleeding, which may be further aggravated by hypothermia, catecholamine use, etc. There may be immunological effects because of brain death process, because it causes release of pro-inflammatory substances like tumor necrosis factor alpha and interleukin 6 and other interleukins. And presence of these two factors will indicate malfunction of the donor heart. And moreover, because of release of these factors, these organs which are to be retrieved will be immunologically activated. So there is possibility of graft rejection after transplantation, which is more after cadaveric donation rather than live donors. Now, what are the management goals? The list includes everything should be targeted to be normal, just like any other patients. But to remember easily, one must remember about rule of hundreds, where one must target systolic blood pressure more than 100, urine output more than 100 ml per hour, PaO2 more than 100, hemoglobin more than 100 gram per liter, and blood sugar 100% normal. Now, these patients will have to be treated in the ICU, not in a ward setting, because it requires intense hemodynamic monitoring and all other measures. One must stop all these unnecessary drugs like sedatives and analgesics and actively identify and treat any other current infection going on. So antibiotics will have to be continued just like any other patient. Now, what is the hemodynamic goal? The goal is for adequate perfusion pressure for optimal tissue oxygenation, but it would depend on the degree of hemodynamic instability. If it is mild, it can be controlled with fluid resuscitation. If it is moderate to severe, then inotropes or vasopressors will have to be added. If nothing helps, then one should go for hormone replacement therapy. But one must remember that the initial hypotension is there in brain dead organ donors in almost 80% of cases. If this hypotension is sustained, that may lead to graft dysfunction. So these are the hemodynamic goals, which I have discussed at some point of time that one must ensure. And about the vasoactive management, if despite adequate fluid therapy, the systolic blood pressure is less than 100 millimeter of mercury, then so in that condition, NORAD may be given. It has advantages in the form of it improves the renal and coronary blood flow. Otherwise, if nothing helps, then go for vasopressin. It helps treating the diabetes insipidus, decreases catecholamine requirements for hemodynamics. So that way, nowadays, it is the first choice of vasopressor for donor resuscitation. So if nothing else, go for hormone replacement therapy, which includes 4 hormones. One is vasopressin. It helps in DI management. IVT3, it improves the cardiovascular stability. Insulin for treatment of hyperglycemia, and methylprednisolone, which acts as an inflammatory modulator. Now, pulmonary care. Suddenly, from brain protective measures in head injury patients, which are the usual organ donors, the long protective ventilatory strategy has to be opted. So that means there is low tidal volume and PaCO2 should be targeted to normal with normal pH, and the PaO2 should be more than 100 millimeter of mercury with low FiO2 and low P. The main target is to avoid ventilator associated lung injury. One must avoid hypervolemia and fluid overload, particularly when lung retrieval is planned. Now, temperature control. The goal is to maintain normothermia by any means, whichever is available in your ICU, to reduce heat loss and that can be achieved with reducing the heat loss and active warming. The target core temperature should be normal. Now, control of bleeding, and this can be achieved by replacement of clotting factors like transfusion of FFP and platelet. INR should be targeted to less than 1.5 and platelet 50,000, more than 50,000. And whenever required, like any other patient, blood has to be transfused to keep the hematocrit more than 30%. Immunosuppressive strategies, as I mentioned earlier, methylprednisolone should be given as soon as possible when the brain death is diagnosed. It is a single bolus dose of 15 mg per kg body weight. It helps reducing the immunological activation and reduction of inflammatory responses in kidney, lung, heart, and liver. Nutrition, just like any other patient, the nutrition will have to be continued. Insulin has to be infused at 1 unit per hour, and blood sugar should be targeted to the normal levels. Now, just to summarize my talk, the diagnosis of brain death is primarily clinical. The prerequisites should be fulfilled before the diagnosis. Ancillary tests are not mandatory, although they are desirable, and these patients should be managed preferably in an ICU setting. And one must target to reduce the negative consequences of brain death on organs suitable for transplantation. And to optimize these organs, one must target for optimal hemodynamic monitoring, adequate fluid resuscitation, and intense vasoactive medication, and not to forget immunosuppressive therapy. Thank you very much.
Dr. Rath has presented in a very nice manner, in a very excellent manner, on the brainstem death and the management, the optimization till the retrieval. I congratulate him. I want him to throw some light on the BSD certification committee, because there are so many legal and medical legal issues. So BSD certification committee, constitution and
people they constitute this committee.
Yeah.
That's what you asked, Dr. Arora?
Yeah.
Okay, so that includes 2 clinicians. I have defined the clinicians and the treating physician and the hospital administrator. So 4 persons are authorized to do that. They form a committee.
Yeah, and the member of committee should be other than the treating physician, but treating unit in charge, may it be medical side or surgical side. One hospital administrator, one neurophysician or neurosurgeon, anesthesiologist or internist, and one physician other than the treating physician. Yeah.
Yes.
So in our institute, 4-member committee is there. Yeah. And from audience, if there is any question, Mr. Sir has nicely described all the aspects. If any question, then you can ask from him. Or you can type in chat box also. Sir would be happy to answer the queries.
Sir, as soon as we get any questions, we'll inform you, and then you. Right now, we have no questions.
Okay. So we move on to the next topic. The next topic of the session. The next speaker is Dr. Mangal Dave. He is consultant anesthesiologist and head of department, Gokul Hospital, Rajkot. He is having 18 years of experience in private and institutional practice. Since 12 years, he is practicing at Gokul Hospital and working mainly in neurospine trauma and high-risk anesthesia cases. He is famous for the Testscope video laryngoscope. and he would be speaking on the very important topic, posterior cranial fossa surgery. I would invite him for his deliberation. Dr. Mangal Dave.
Also, Dr. Divya ma'am has joined now.
Thank you very much, sir, for the kind introduction. Simran, you can please play the video. Respected seniors and colleagues, good morning. Myself, Dr. Mangal Dave, consultant anesthesiologist and head of department of anesthesia at Gokul Hospital, Rajkot. And I have been practicing since 18 years. My main work in neuro, spine, trauma, and high-risk anesthesia cases. And today, I'm going to give a lecture on posterior fossa surgery anesthesia, clinical pulse. According to the skull-base divisions, the cranial fossa is divided into anterior, middle, and posterior cerebral fossa. And the largest of three cranial fossa is the posterior fossa. And the contents are cerebellum, large portion of brainstem, lower midbrain, pons, and medulla. It also contains 3 to 12 cranial nerves and its nuclei, and other important efferent and efferent pathways of nervous system. The boundaries of posterior fossa, anteriorly it is bound by dorsum celli, sphenoid and basilar part of occipital bone, posteriorly by squamous part of occipital bone, laterally with petrous and mastoid part of temporal bone, superiorly by tent or tentorium cerebelli, and the base is found by occipital bone. The clinical significance is posterior fossa is a compact and rigid compartment, and it has poor compliance, and a small addition in volumes like with hemorrhage or a space occupying lesion within the posterior fossa can result in significant elevation of compartment pressure, leading to life-threatening brainstem compression. CSF pathway in cerebral aqueduct is also very narrow, and cause obstruction of it can cause hydrocephalus and raised intracranial pressure. Therefore, anesthesia for posterior fossa surgeries presents significant challenges. What are the indications for posterior fossa surgery? Posterior fossa surgery indication mainly is tumors. Tumor is the commonest pathology. Especially in pediatric patient, almost 60% are tumors. Although there can be arteriovenous malformations, aneurysms, cerebellar hematoma or infarct, or for microvascular decompression of trigeminal neuralgia or hemifacial spasm, or craniocervical abnormalities like atlantoaxial or atlanto-occipital instability, and Arnold-Chiari malformations. Which are the different positions given for posterior fossa surgery? There can be supine with head turn position, lateral, park bench position, prone, and most of the important sitting position. This is the picture showing supine with head turned to one side. Head is turned to opposite side, and placement of sandbag under the ipsilateral shoulder to minimize stretching of brachial plexus is given. This position is mainly utilized for MVD or microvascular decompression, for example, for trigeminal neuralgia, hemifacial spasm, and glossopharyngeal neuralgia. And CP angle tumors also can be done in this position, lateral position. The patient is turned to lateral side, and pressure points are protected with soft pillows, and head is rested on either sandbag or horseshoe or with pin. The advantage of the position is it provides drainage of blood and CSF with gravity, and the amount of retraction is reduced. park bench position is a little modification of lateral position. Here the head is little more flexed and it facilitates access to midline structures, but due care should be taken to avoid pressure at pressure points. Prone position. The patient is completely made prone and he lies on bolsters. The head is either fixed with pin system or horseshoe also can be utilized. This position is used for all midline tumors, AVM, aneurysm, etc. When the horseshoe is used, care should be taken for eyes and pressure points and abdominal pressure. To minimize abdominal pressure and surgical bleeding, horseshoe and bolsters are used, so there is no undue pressure on abdomen. On the right side, you can see the photograph of real surgery going on with the position of anesthesia workstation and surgeon and assistant working on microscope. Again, photographs of actual surgery. The patient is made prone. There is a tongue applied with head, traction, and the head is resting on horseshoe. You can see the padding in front of eyes to protect from any pressure, and see how the patient is fixed over bolsters. The another photograph is showing the surgery and microscope in situ. Sitting position. Sitting position has its own advantages, factors affecting anesthesia and outcome. Sitting position gives good access and comfort to the surgeon. Blood and CSF drains from surgical site. It gives advantage of gravity. The light and position gives easier access to midline structures to the surgeon, but it causes postural hypotension. So patient of extreme age, cardiac or respiratory compromise need to be avoided. From anesthesiologist perspective, the sitting position should only be given in a good setup with Simran, please check the audio. Now this picture is showing how uncontrolled hypertension, left heart shunt, cervical spine instability or fractures. Relative contraindications are patent foramen ovale, uncontrolled hypertension, extremes of age, and severe autonomic dysfunction. Now this picture is showing how we give a sitting position at our setup. This is the operation table. The patient is induced in supine position, and gradually the table head end is elevated 15 to 20 degree for every 2 to 3 minutes to make the patient sitting. And the pillows are placed below the knees and under the arms for placement of the patient. We should be fixing the anesthesia circuit and monitors properly so that there is no disconnection or dislodgement of circuits. Because intraoperatively we get very little access to the patient. This is where the anesthesia workstation lies and the patient position. Once the patient is made sitting, the head pins and the frame is applied to the patient. And this is how the surgeon stands and the trolleys will be placed to give a fair idea of anesthesia workstation. We get a very little access to the patient as such. So everything needs to be fixed in advance. because once the patient is draped, we lost the vision. We have a very little access and everything is under monitor care. So this is the ultimate position, how the anesthesia workstation, the surgical instruments and the microscope and the surgeon and assistant positions will be there. This is the actual patient, female of young age. On the left, you can see the padding under the chin of the patient to avoid any undue flexion of the neck and soiling of body through saliva. The gauze piece or gamgee is placed, the pillow in the lap of the patient, and on the right of photograph you can see the crepe bandage application to improve venous return to the patient. Again, photographs of surgeries in sitting position. On the left is being operating with naked eyes. On the right side, it is the surgery under microscope. And you can see the position of anesthetist and anesthesia workstation in the right photograph, and where the instrument trolleys and assistants are standing. We are sitting very much away from the head end. Anesthetic considerations for posterior fossa surgeries. Thorough evaluation of the preoperative neurological condition and cardiorespiratory status are important for safe conduct of anesthesia for posterior fossa surgeries. Preoperative evaluation include evaluation of cerebellar and cranial nerve dysfunction. Presence of lower cranial nerve compression and dysfunction can cause loss of gag reflex. Some of the patients of posterior fossa may already have loss of gag reflex and it can cause aspiration. So in these patients, the care should be taken either to do tracheostomy or post-op ventilation in this like patient. Evaluation of cardiorespiratory compliance. Compromised cardiorespiratory function can lead to hemodynamic instability and poor prognosis. So in these patients with poor cardiorespiratory reserve, sitting cannot be given. Other position also given with very much caution. Evaluation of hydration in electrolytes. Preoperatively, the patient's hydration should be good and electrolyte to be normalized. Evaluation of intraoperative positioning. That is, we have to analyze which position we need to give and whether the patient is fit for that position or not. For example, obese patient will be difficult to give prone position, and cardiorespiratory compromised position will be a relative contraindication for sitting position. Evaluation of airway. Some of the patients will have restricted neck movement, or they can have ankylosis spondylitis and difficult intubations. Anesthesia technique. The goals of anesthesia management in posterior fossa surgery is to maintain intracranial pressure and cerebral perfusion, to maintain hemodynamic stability, and early detection and treatment of any complication if occur. For this, we have to avoid cardiorespiratory compromised patients and extremes of age. We have to take good large bore IV lines, or central line if it is there, it is better. There should be a smooth induction. We can use propofol and scoline or any relaxant of your choice. Intubation, if you have armor tube or that is better. Proper fixation of tube and monitor and taking care of lines while giving position is also important. Proper eye cover and padding to prevent organ damage and eye damage. Crepe bandage application on lower limbs to improve the venous return. And once the patient is reduced, there should be a gradual and slow elevation from supine to sitting to avoid any sudden hypotension. And we do like 15 to 20 degree elevation and waiting for 2 to 3 minutes for the patient to settle, and then again doing further elevation. The monitoring is done by ECG, non-invasive blood pressure, SpO2, end-tidal carbon dioxide is must for all sitting position. Maintenance can be done with oxygen, air, and sevoflurane. Sitting position to maintain blood pressure
mean blood pressure of above 80 millimeter of mercury. Nitrous oxide is best avoided in sitting position. Control of blood pressure if hypertension can be done with nitroglycerin or labetalol drips. Invasive BP monitoring, if it is available, it is good. Indwelling urinary catheter should be done to measure urine output. Temperature monitoring when there is a longer duration surgeries causing hypothermia should be done. Neurological monitoring of electroencephalogram or EEG can be used to detect cerebral hypoperfusion and cortical ischemia. SSEP or somatosensory evoked potential can be done monitoring to monitor spinal cord ischemia. We have to intraoperatively maintain normovolemia. If there is blood loss, we must be giving blood and crystalloid accordingly. Analgesia, tramadol and paracetamol analgesia with local infiltration. Phentermine and dexmedetomidine can be used and also it will help reduce the blood pressure. After the surgery, there should be gradual supination from sitting position to avoid any hypertension. And once we are doing supination, we have to take care that the lines are not stretching or they are not pulled off. Don't hesitate to shift the patient in an ICU or ventilator because these patients are likely to develop macrognosia. If there is any stormy surgical course and likely damage to any lower cranial nerves, we should be ventilating the patients post-operatively. Posterior fossa surgeries, posterior fossa is as such is having very low compliance and it gives very less time to intervene if any complications occur. So better we prevent all the complications. Post-operative management. Extubation will be depending on the pre-operative condition of the patients and intraoperatively course. The patient who was intact pre-operatively and had an uneventful surgery, there can be a smooth emergence and extubation can be carried out. Otherwise, post-operatively ventilation can be done. PONV, post-operative nausea vomiting. All patients of posterior fossa surgery are considered at high risk of PONV because of proximity of vomiting center to the surgical site. Complications are many in posterior fossa surgeries. Excessive bleeding and damage to vital structures during surgery can occur, and we should be prepared with adequate supply of blood. Endotracheal tube or lines dislodgement, accidental extubation can be there during surgery. Air embolism. Small to large amount of air entering into venous system from surgical site can lead to air embolism. And we should be always vigilant, and it is detected by sudden fall in EtCO2, hypotension. On auscultation at a later stage, there will be mill-wheel murmur. The treatment is supportive, 100% oxygen and irrigation of surgical site with saline and saline soaked gauze. Suspected air entry points are sealed. Head level should be made low, below the heart if possible. Discontinue nitrous oxide if it is going on. Vasopressor and suppressive treatment needs to be done. Macroglossia or enlarged tongue. As a result of obstruction of venous and lymphatic drainage, there will be macroglossia, and it can cause post-operatively respiratory obstruction, damage to eyes, nerves, and pressure effect from positioning. Pneumocephalus. If air is entering in cranial cavity, it can present as pneumocephalus, and in recovery, there is a delayed recovery, there is agitation of the patient post-operatively, confusion, and the diagnosis is made by CT scan and treated accordingly. High flow oxygen can be given. If there is much more pneumocephalus, burr should be done to remove excess air. Complication, quadriplegia. When there is a severe stretching of spinal cord with acute flexion for a prolonged time, it may cause a dangerous complications of quadriplegia to the patient. And in pediatric patient, there is a posterior fossa syndrome sometimes detected. It occurs in children and defined as a temporary and complete loss of speech in children after posterior fossa surgeries. To conclude, posterior fossa surgery in sitting position has its own advantage for patient and surgeon, but because of dangers associated with the sitting position, the popularity of sitting position is nowadays very much reducing. Though with meticulous planning and care, we can anesthetize the patient for posterior fossa surgery very safely. Thank you very much.
Thank you, Dr. Dave. Now, co-chairperson Dr. Divya Shukla has joined. Now, I will request her to conclude this session and to introduce the next speaker, Dr. Divya Shukla.
Good morning, madam.
Good morning, sir.
Dr. Divya Shukla is the assistant professor at Bangalore College and Research Center, Bengaluru. She has multiple publications and national and international journals. Welcome, madam.
Thank you, sir. But I am not able to upload the video, sir. Video is not coming.
No, madam, you need to introduce our next speaker, madam. Simran, can you please bring the slide for our next speaker?
Sir, I had one to you, sir. First.
Arora sir, can you introduce Dr. Madam, please?
Hello.
I think Dr. Divya Shukla is there as our co-chairperson. Dr. Divya Shukla, are you there?
Yes, sir.
I would request you to introduce our next speaker. Her CV is there on the screen.
Sir, I am not able to read the name, sir. Name I can't.
So in that case, Dr.
Dr.
Arora, can you please introduce Dr.
Rashmi Dev Pujari. Yeah. Yeah. Dr. Rashmi, she is senior consultant at the Department of Anesthesia, Jaslok Hospital. Experience and special interest in neuroanesthesia, neurocritical care, and patient safety. She is currently Vice President of ISNSCC and GC member of ISA Maharashtra, and also Organizing Secretary of ISA NSCC 2018. She has organized multiple CME for Jaslok Hospital and presented many papers in state, national, and international conferences. Published a book on neuroanesthesia, that is Practical Tips Neuroanesthesia, and she has contributed 3 chapters. Now I would and also a recipient of distinguished NME National Board of Examination Teacher Award in July 2019. So I request Madam for her deliberation, her presentation.
Thank you, Dr. Arora. Thank you very much for that invite.
Good morning, all. I would like to thank the organizing committee for giving me this prestigious platform
of Isacon 2020. And I would like to congratulate the organizing committee for doing such a big, wonderful job. Thanks to Dr. Tarlika, doctor, who has been the scientific chairman, who has invited me for this talk and has given me the liberty to choose my own talk. My talk today is anesthesia concerns for deep brain stimulation for movement disorders. I chose this specific talk because DBS is now an established treatment for Parkinsonism. Though most of the audience may not be into doing anesthesia for these cases, however, they will now encounter, as more and more patients have DBS, for other surgeries and concurrent surgeries, and then they need to know the what the surgery is all about and how to take care of these implanted DBS stimulators. So in the historical aspect, in 1939, Mayers started transventricular surgery of the basal ganglia for these Parkinson's disease patient, but it was abandoned due to lots of complicated because of high mortality. Stereotactic closed functional neurosurgery in patients for a market turn to medical treatment of Parkinson's. And pallidotomy and thalamic stimulation was then again restarted in 90s by 1991 by Benabel and 1992 by Leckman. Deep brain stimulation surgery was first approved in 1997 to treat Parkinson's disease tremor, and then in 2002 for treatment of advanced Parkinson's syndrome. So in the next few minutes, I will talk about anesthesia concerns and talk about in short what is DBS, when is it done and how, anesthetic goals, the patient surgical and disease-related consideration, the perioperative complications and avoidance, and also anesthesia concerns in patients who already have a deep brain stimulator. So what is DBS? It's a surgically implanted medical device called a brain pacemaker. It sends electrical impulses to the brain. It's traditionally used to treat movement disorders such as Parkinson's disease, essential tremors, and dystonia. Three major components are there. There is a implanted pulse generator, which is a battery-powered neurostimulator, which sends electrical pulses to the brain to interfere with the neural activity at the target sites. There's a lead. It's a coiled wire insulated in polyurethane with flow platinum iridium electrodes, and is placed in one of the three areas of the brain which are targeted. Extension is the insulated wire that runs from the head down by the side of the neck behind the ear to the IPG, which is placed subcutaneously below the clavicle, or in some cases in the abdomen. So in these patients, a patient undergoes an MRI which maps out the target areas for the brain. An incision is made in the scalp. The electrodes are then precisely inserted through the burr into the target area of the brain, and two wires are then threaded behind the ears in the second stage down the neck to a pulse generator, which is usually implanted near the clavicle, just like an ICD. It affects changes in the brain activity in a controlled manner. They are reversible effects. The DBS also kicks in only after a number of weeks for psychiatric disorders. And how it works is totally not explained by the directly inhibiting mechanism which it does. So we need to do much more research in understanding the brain neurophysiology. Indications are for Parkinson's disease, essential tremor, and dystonia. Most of these patients improve a lot after DBS. The other indications being chronic pain, psychiatric disorder, depression, OCD, traumatic brain injury, epilepsy, Alzheimer's, etc. And there are different nuclei which are targeted in different diseases. So anesthesiologist's goal is to keep our awake cooperative state, to preserve the movement disorder as tremor for mapping purposes, and also to assess stimulation to induce to see if there are any adverse effects. Well, most important, we need to take care of the patient comfort, hemodynamic stability, and respiratory sufficiency. So targets. So let us see what the reason why Parkinson's takes place. In health, a very finely adjusted neuronal circuits of inhibitory and excitatory neuronal interplay exist between the basal ganglia, the subthalamic substantia nigra, the the thalamic nucleus, and the cortex. This controls our day-to-day involuntary movements. And in Parkinson's, which is a degenerative disease, the dopaminergic cells in the substantia nigra degenerate, and therefore this whole neuronal circuitry is disturbed, and Parkinson's gradually develops in the patient in the form of tremor, rigidity, and dyskinesia. And the targets for DBA stimulation in Parkinson's is the WIM nucleus, the STN, and the GPI. It is done with a team of specialists, neurosurgeons, neurologists, anesthesiologists, neurophysiologists, radiologists, and psychologists take part. The surgical candidates have symptoms of tremor, rigidity, akinesia, bradykinesia, freezing of gait, where the medical therapy is maxed out. And we have to see that these patients who are selected for DBS are still L-DOPA responsive, do not take very old patients, and rule out Parkinson's class syndromes. The neurophysiological, psychological clearance is to be done. There should be no dementia or cognitive defects, MRI, there should be no structural lesions, etc. It's important to educate the patient and the family to give them a realistic expectation. So the issues can be then divided into patient-related issues, the surgical issues, and the disease-related issues for the anesthetist. The patient-related is find out what is the primary disease, whether it's Parkinson's, dystonia, essential tremor, or some other disease which is come for DBS. We need to select the patient carefully and evaluate these patients. Do not take very old patients. Treat the concurrent medical issues, optimize the patient. Multiple drug administration can give rise to risk of drug interactions, and that has to be kept in mind. And during in the off state, drug off state, there is a deterioration of symptoms, to please keep it in mind. Surgical related, there is a rigid head frame, manipulation of the airway becomes difficult. Positioning of the patient is semi-sitting, which can be difficult and uncomfortable for patient. And there can be a risk of venous air embolism, where the dural veins can be exposed outside to the atmosphere. The procedure duration is long and may lead to fatigue and discomfort. MER recordings are interfered by anesthetic agents. Then after MER, almost always you do a macro stimulation, and this requires a awake and cooperative patient. Complications are many. We have to take care of intracranial hemorrhage, stroke, seizure, hypertension, decreased level of consciousness, nausea, vomiting, airway obstruction, excessive pain, and neurological deficits due to an ICH. The disease-related issues are where Parkinson's disease can have respiratory problems, and there is abnormal control and function of the upper airway. There's a poor cough, and they can be associated COPD and OSA. There is a very, very noticeable pharyngeal muscle dysfunction, which can give rise to risk of aspiration. There's autonomic dysfunction in form of orthostatic hypotension, abnormal temperature regulation, and there can be cardiovascular instability, cardiac arrhythmia, hypertension, dependent edema, etc., dysphagia, difficulty in micturition. We need to take care of that, and in our institute, we categorize all patients. We need to be worried about, careful about the worsening of the symptoms. There's also adverse effect of antiparkinsons, so we can have abnormal glucose, hypertension, and orthostatic hypotension. There can be depression, hallucination, tremors, and muscle rigidity interfere with positioning. Speech impairment and confusion give rise to very poor communication, and anti-Parkinson's drugs can interfere with anesthetic agents. So essential tremors can give rise to bradycardia due to beta blockers. The other patients which we do is dystonia, and there is a risk of hemodynamic instability and laryngospasm in dystonia, which is very, very noticeable, and we have to be very careful that these patients can go into laryngospasm even when they are awake. There is dysphonia. Usually patients of dysphonia have very poor communication skills. So this is done in 2 stages. Stage 1 is implantation of stimulatory electrodes. Stage 2 is implantation of generator. So in stage 1, we can either do conscious sedation or GH. Stage 2 is always general anesthesia. Stage 1, in our case, we always do a preoperative diagnostic 1 day before. You may need sedation for transfer to MRI and CT, and a target localization is done. You might require sedation or GA. Most of the times in our cases, we use a GA for target localization. Once the second day in the OT stage 1, you do a frame fixation with local anesthesia or scalp block. Complications could be vasovagal or even anxiety associated hypertension. And I see that most of these patients get dexmedetomidine even before, so that they do not become too much anxious. In stage 1, the application of the the application of the stereotactic arc system is fixed to the table. Draping and burr hole placement is done. Burr hole makes multiple pathways for MER, and it also must accommodate anchoring device. We choose the monitors and the drugs. So a well-informed anesthesiologist is one of the best monitors, where you need to know what are the stages and what is happening to the patient exactly. And as usual, monitoring of oxygenation and ventilation, capnography should be done. ECG and IBP and temperature monitoring is also mandatory. Neurological monitoring is always done. There's a neurologist to help us for that. So these are the equipments in the operation theater. And as you can see, there's a micro drive which fits on the ARC device. And this micro drive has holes for the platinum microns electrodes to go inside the brain via the burr hole, and it records. The recording is done in the computer. So what happens, how do you find out which is the subthalamic nucleus? So each nucleus has its own signature graph, and even the graph. So in subthalamic nucleus, it is marked by irregular firing pattern and increase in the background cellular activity. And here is how a subthalamic nucleus will seem to us, and we can go ahead with that. So once this is done, then we do the macro stimulation. As I said, macro stimulation, you need an awake patient, and it is done by bipolar. What is most important about macro stimulation, and that the internal capsule is very much near the subthalamic nucleus. And if we should not, we should be careful that our electrode does not impinge on the internal capsule. So if it is, the stimulation is done, and if there is any problem in the upper extremity, lower extremity, any motor movements, please be careful, change the thing. So if the our electrode is too medial, the third nerve can be involved. And similarly, you can get paresthesia where if the electrode is not placed properly. So the electrode is then secured with a cap, and then an image is taken and stored for the next side. So for us, what is important is to control the BP to avoid ICH. An infusion of labetalol, NTG, clevetapil, or hydralazine can be used. I use labetalol and NTG. Try to keep the blood pressure between 140 systolic. Do not go above it, or otherwise keep it between 20% of the normal. Functional mapping, I do not use any sedation, actually minimal or no sedation. And sedation, sometimes you can do with remifentanil if it is available, or otherwise dexmedetomidine. But use it judicially and stop it 15 minutes before the mapping. In the event of airway emergency, a means of releasing the patient from the stereotactic frame must be easily available. And therefore, we have an emergency trolley which is kept near. And if you see on the far right of the patient, there are 2 keys. These keys can help us to take the patient off the frame fast. Emergency drugs in the form of anti-epileptics, propofol are kept. Then nasal airways are kept. And also I keep an intubating LMA just in case I need to do an intubation fast, but this now is replaced by the LMA Supreme, which is as effective. I also keep a cannula, which is attached to a capnograph, so I can get a readout of end-tidal CO2 in case of respiratory emergencies. This is an intubating stereotactic frame, and you can do a fiber optic intubation with the help of this frame. And this is just a patient who collapsed or had a respiratory problem after of a dystonia after before the start of the surgery, and I had to intubate him. And it was a difficult task, but not an impossible task. So be ready for intubation as and when you like. As far as the anesthetic agents are concerned, I would not use benzodiazepine, because not only does it affect the MER brain mapping, but it also impairs the level of consciousness. Opioids also we do not use because they give rise to rigidity. Propofol can give rise to dyskinesia, abolish tremor. I still use dexmedetomidine, and hypotension and bradycardia can be avoided if you use it in a lower dose. And there are many studies in which MERs have been done under GA, and they have found that it is possible to do an MER under GA, and there are not much difference between the amplitude and pattern of discharge within the STN. Here is another study in which the general anesthesia were used for MER in advanced Parkinson's disease, and they concluded that STN can be done for advanced Parkinson's is possible with good clinical results. There is another study in which MER was done in the same patient. 10 days ago, the MER was got, and for some reason, the second side could not be done. 10 days after the patient needed to be have GA, and they found that stimulation can be performed under certain conditions, and there are not much, though there are difference in the signals, there's not much of changes, and we can accept the MERs under GA. So I just want to refer to this study by Irene Rosette, and she has used dexmedetomidine since the early 2000s, and we still use it now, and it's gives a lot of help for us for these cases. So what are the immediate complications? There can be a loss of airway, and you need to keep your emergency safety procedure in view. Keep a LMA, which can be immediately put in the frame. There can be epilepsy, though very rare in Parkinson's disease. ICH is one very important thing which has to be recognized, and usually if the patient deteriorates neurologically, be careful. Air embolism has been recorded, and if we keep a capnography for a spontaneous patient, you can sort of take care of this, and it can also precede by a violent cough. Be careful. Agitation and combativeness is something which we deal with, we have to deal with and take care of it, and dexmedetomidine helps a lot in this. So this in the stage 2, there's internalization of IPG. The choice of anesthesia can be TIVA, GA, LMA, LA also, and it's the same as internalization of a cardiac pacemaker. So I preferred general anesthesia. So we come to this important part of the topic, is that is anesthetic management of patients with an implanted DBS device undergoing surgery. So preoperatively assess the patients for indications, optimize the medical diseases, and optimize the current medication. Obtain the following information related to DBS device from the patient: the DBS information card or DBS physician. Find out the DBS model, its location, its large check and battery change, current settings, programmability, and prior device complications. See, find out whether the severity, what is the severity of symptoms when the device is turned off, and learn to use the patient programmer, especially how to turn the device on and off. Consult the patient's neurologist or DBS physician to discuss specific precautions and post-operative assessment of both the patient and the device, and do an X-ray test to identify the path of the DBS device wires. Arrange with the device representative DBS physician for interrogation and adjustment of DBS setting. Intraoperatively turn the device off to minimize the electromagnetic interference, and also turn the device off after induction of general anesthesia if you see that there is a recurrence of the symptoms once the device is turned off. So let the device be on, induce the patient with general anesthesia, and then turn the device off. Regional anesthesia, increase the sedation. You need not turn the device off. Turn the DBS device on before reversal of anesthesia and emergence. For emergency surgery, and when programmer is not available, proceed with precautions for electrocautery. Precautions of electrocautery is just like cardiac devices, and use a bipolar cautery mode with minimal power setting. Use intermittent irregular burst, short intermittent irregular burst. And if a unipolar cautery mode is utilized, place the grounding pad in such a way that the current active electrode does not pass through the DBS. So post-operatively, a neurological examination is important. In conclusion, be familiar with the major stereotactic system, select appropriate technique drugs, provide motionless field, safe conduct of MA MAC and GA in radiology OR, anticipate and treat complications as they arise, and learn to manage patients implanted with DBS implants coming for surgery. So thank you. And I would just like to show you a 20-second video, which is self-explanatory. This is the patient which we have done recently, and he's a pediatrician who's very happy with the outcome now. Thank you. Stop share.
No?
Hello.
Hi. Hi, ma'am. Very wonderful session. Very crisp and clear data. I just have one doubt. Can you throw some light on some people use ice cold saline for prevention of intra-op seizures? Do you have any experience with that technique?
Ma'am, you're talking about Shiza surgery. In this case, this is a functional neurosurgery where very deep inside, and usually deep brain surgery is done for Parkinson's disease and not for epilepsy. So you are right that when you are doing mapping for Shiza patients, and when this patient is either awake, then ice cold, and he develops a Shiza at that time, you get put infiltrated with ice cold saline. So these are two different scenarios. I'm talking about Parkinson's, in which there's only a burrow through which. But if there is a Shiza, see, Parkinson's patients are very resistant to Shizas. So I haven't seen any of Parkinson's patient having intraoperative Shiza. But if there is, like I had said, there's a complication of 3% or so. This is the general literature rate. You start, the first thing is to give an anticonvulsant or even midazolam if you have it with you, or propofol, and immediately you have to take the patient off from the frame and intubate or go ahead and take care of the respiratory. If it arrests by itself, then there is no need to do much. But what is most important is this patient's head is fixed to the table, and in case of a severe tonic-clonic Shiza, they can have a lot of damage into the cervical canal. Okay, does this answer your question?
Thank you so much, ma'am. Mangal sir, hello.
Yes, madam. Good morning.
Good morning. Good afternoon, sir.
Good afternoon.
Sir, I have one very favorite question for PG examination. Some examiners will ask is posterior fossa surgery. Sir, what to do with for pre-op pre-medication for pediatric kids, sir? So generally those kids will be crying to enter the OT. So there are two school of thoughts. Some people tell to give pre-medication with midazolam or any anxiolytic. Some tell no, because it might raise ICP and they might make the children drowsy. So what is your say?
Madam, there is no contraindication to midazolam. We can definitely give.
Pre-medication, sir.
Yes, ma'am.
Especially in pediatric cases.
Yes, ma'am. Sure, we can give.
Because what that.
Yeah.
Midazolam syrup, sir, right?
Like Dr. Mangal said, there are certain scenarios where you can give midazolam as pre-medicants, even these are posterior fossa surgeries, provided you are sure about there is no hydrocephalus, there is no features of raised ICP, the child to receive it, and you have proper nursing backup, and it is given in presence of you. There are a few scenarios, but in routine, I'm from AIMS, we don't practice it because we cannot afford to do all those things. usually we avoid all those things. But there are centers, some places, the practice is provided you fulfill all these criteria. Otherwise, it is better to avoid.
Yes, sir. Thank you so much, sir. That was a very nice discussion. Kishore, sir, anything we can ask? We can wind up this session, I think.
Yeah, we can wind up this session.
Thank you all.
Thank you. Thanks all the speakers. Thanks organizing committee.
এখান থেকে হটস্পট লাগাবো তাহলে আমি তুলছি মেলটা ভালো লাগতো
Welcome, welcome. Yes, sir. Welcome.
Sorry, Dipash, remember for inconvenience of last meeting, but I would really like to invite you in this meeting. She is chairman of our, so please welcome her. Good morning, Dr. Ruchi Verma. I would really like to invite you also for joining this session and for your time. Thank you. Dr. Ruchi Verma is
Yes.
She is experienced in neuro anesthesia and neurocritical care for last 7 years, and delivered lecture in various CMEs. Also involved in teaching and training of neuro anesthesia for PDAF students. So you are with us. It is very proud moment for us. Thank you for joining us.
Thank you for inviting me for the session.
Congratulations of outstanding women researcher in anesthesiology. I would request chairperson to invite our speaker, Dr. Prasanna Bitkar.
Thank you for giving me the opportunity to invite Prasanna sir. The Prasanna sir is MBBS, MD, DNB, DM in neuroanesthesiology from AIMS, and he is a professor and in charge in the division of neuroanesthesiology, Department of Anesthesiology and Critical Care at Chipmar, Pondicherry, India. Welcome, sir, for the session.
Hello, good morning. I am Dr. Prasanna, Professor and Head of Neuroanesthesia Division at Chipmar Hospital, Pondicherry. At the outset, I would like to thank the organizers for having given me this opportunity, and I would also like to congratulate the ISA Gujarat State Chapter as well as the national body of the ISA for having conducted this hybrid conference in such a successful manner in these difficult times. So let me go back to my subject and share the screen with you. The topic what I am going to discuss today is on intracranial pressure monitoring in traumatic brain injury patients. So in the next 15 to 20 minutes or so, what I am going to discuss is the intracranial pressure monitoring. So the outline of my discussion will be what are the intracranial contents, how they are going to affect the intracranial pressure, what is the normal intracranial pressure, what are the indications for intracranial pressure monitoring, what are the different methods used for intracranial pressure monitoring, and some on optic nerve sheath diameter, and to summary. So let me go back to the discussion today. So as we know, for all the people who are practicing neuroanesthesia regularly or occasionally, we know very well that raised intracranial pressure is a common problem in the neurosurgical practice. And we know with our experience that whenever it is raised, it is associated with increased morbidity and mortality. Hence, early diagnosis and treatment of this definitely can improve the outcome of these neurosurgical patients. That is why monitoring for the ICP is an important tool for diagnosing the raised intracranial pressure early and to treat it to get better outcomes. So what are the intracranial contents? As we know, brain, blood, and CSF are the contents. 80% of the intracranial contents is brain, and the 10% is blood, and the another remaining 10% will be CSF. We know that these all three are placed in a rigid skull. So hence, any expansion or anything like a hematoma which happens intracranially has to compromise one on this. So that is what is called as a Monro-Kelly doctrine, that contents or the volume of the intracranial content is fixed. So as we can see from this slide, so this is the normal brain. Once there is some mass or a hematoma which keeps on increasing, it compresses the venous volume, CSF. Then ultimately, when there is no compensation available, leads to herniation of the brain, that we call the shift of the brain from one compartment to another. So what is the normal intracranial pressure? The intracranial pressure depends on the age, the body posture. For example, if the standing position, it is less as compared to the supine, and also on the clinical conditions, what we are anticipating. So in the adults and the older children, it is around 10 to 15 millimeters of mercury, lesser in children and in infants. So when do we treat it? When do we call it as intracranial hypertension? As per the Brain Trauma Foundation guideline, 22 millimeters of mercury is the limit which requires the treatment. And ICP, anything more than 40 millimeters of mercury is called a severe uncontrolled intracranial hypertension, which is not controlled, then can lead to catastrophic brain herniation and death. So hence monitoring of the intracranial pressure becomes important. You can see how the pressure and volume changes in the intracranial contents can lead to the changes in the pressure and volume. So in the x-axis, there is an intracranial volume. On the y-axis, there is an intracranial pressure. So in the initial parts, when there is a volume increase, what we call as a good compensator reserve, here it gets compensated by the reduction in the venous volume and the CSF. But after some extent, when there is still more increase in the volume, then there, with a smaller even increase in the volume, there is a steep rise in the pressure. This is the phase where it is called as poor compensator reserve, and subsequently when not treated lead to herniation. That is why we need to treat the patient somewhere here, or we have to keep the patient here in a good compensator volume. Hence, the monitoring of the pressure is very important. Causes of raised ICP, it can be many. There are three contents, as I already discussed. Any of increase in any of these three, or can also lead to increase in the pressures. Like for example, there is a tumor, there is a hematoma, traumatic brain injury leading to contusions, raised ICP, or diffuse cerebral edema. In conditions like hydrocephalus, vascular malformation, CVT, these are all the conditions can actually give rise to increase in intracranial pressure. So what will happen eventually if this pressure is not treated? Then brain has, there is, for example, you see there is a huge hematoma here in the right hand, in the left right hand side of the brain. When it is not treated or evacuated, it has no other option. It pushes the brain, and to accommodate this, brain has to go somewhere. This is what you call it as a herniation. There are several types of herniation what we are aware. The uncal herniation, the central herniation, the subfalcine one, which we commonly see day-to-day practice when in patients with cerebral tumors, what we call it as a subfalcine herniation. Like this, brain has no other option than to go somewhere else. That we call it as a herniation, which is associated with disastrous complications. But why do we monitor actually ICP? What is the importance? The importance is, as we know that any hypotension or reduction in cerebral perfusion pressure is associated with bad outcomes. Hence, we have to maintain the CPP at any cost. CPP is nothing but MAP minus ICP. So if we monitor the ICP, we can maintain the CPP better. And if the ICP is normal, actually we can exclude intracranial hypertension and need not treat it aggressively. And if the ICP is high and we reduce it to some, whether these treatment what we are giving are actually acting or not, we can make out, assess whether this therapy what we are instituting, whether they are reducing the ICP or not, if we have a ICP monitoring. If we do not have it, then it is difficult to make out. We may have to rely on either a radiological scan or a clinical improvement in the patient. And if the ICP when we are monitoring is normal, then the potentially dangerous treatment, like for example, excessive periods of aggressive hyperventilation or the excessive use of mannitol or hypertonic saline can be avoided. And if we have an intraventricular catheter in place for the ICP monitoring, then we can withdraw some amount of CSF, which can immediately reduce the intracranial pressure. So these are the advantages of ICP. Now look at what is the indication. As far as the head injury is concerned, this is what is the standard recommendation from the Brain Trauma Foundation guideline, that any abnormal patient with GCS less than 9 with an abnormal CT scan or any normal CT with more than these two risk factors is required to have an intracranial hypertension. So in the non-trauma patients, anywhere where the ICP you expect it to be higher, you can monitor. But in particularly in non-trauma patients and all, CNS bleed, SAH patients, all these patients, wherever the raised ICP is there, you can use it. So what are the different types of ICP monitoring? Now we know that ICP monitoring is important. Let us look at what are the different types. So broadly, they can be classified into invasive and the non-invasive. The most commonly we use on the present day still is the invasive one, though non-invasive multiple techniques are coming up and still they are not being greatly validated so that to replace the invasive monitoring. So as far as the invasive monitoring is concerned, we have these 4 to 5 types which are commonly used. The intraventricular catheter, you place a catheter in the lateral ventricle and connect it to a water strain gauge and monitor the intracranial pressure is the most commonly used, and it is the gold standard for the management as well as the monitoring of the intracranial pressure. We do have an intraparenchymal sensors where you keep in the brain parenchyma in the frontal cortex and monitor the pressure using different types of this one. I'll come back to it again. The epidural subdural catheters or the subdural bolts are not very commonly used nowadays, though they were being used 20 years before. Now the intraventricular and the intraparenchymal sensors are the one which most commonly used for the monitoring of the intracranial pressure. As I already stated, anything more than 22 millimeters of mercury intracranial pressure has to be treated on an urgent basis. So when we connect this to a connector monitor, how does the waveform looks like? The waveform essentially looks like a arterial waveform, what we see day to day. It has three waves: percussion wave, the dichrotic wave, and the tidal wave. So the percussion wave, it reflects the cerebral blood flow, what is coming to the P1, that is the P1 to the brain, and the P2, the dichrotic wave, reflects the intracranial compliance. So these are the essentially these two important ways what we have. So you can see here in this video, there is a normal arterial line like the waveform, what it is coming with the ICP of 20. You can make out P1, P2, P3 in this again. So what happens when there is a reduced intracranial compliance or there is a raised intracranial pressure? This P2 becomes more than P1. That shows that there is a reduction in the intracranial compliance. That is the indicator that this patient needs a urgent treatment. So you see in this graph, in this video, so you can see that the P2 is this one and there is a smaller P1. P2 is more than P1 and the ICP is 42 millimeters of mercury. So you can see here, I will play the video again. You see here P2 is more than P1. You can make out in this. That is what is the shows that there is a poor intracranial compliance, hence needs urgent treatment. Okay, so you see in this slide also, you can see P2 slightly higher than P1 again. So suggesting that there is a raised intracranial pressure. So you can see again, and now this one you see once the CSF is drained, the P2 is coming back to normal. It is less than the P1 now. So you can make out that the ICP is reduced. So removal of the some amount of CSF is the most efficient way of reducing the intracranial pressure. But the only thing what you need or the necessity is there has to be the ventricle should not be compressed and the dilated ventricle should be present to put an intraventricular catheter. So how do the waveform looks like? The Lundberg has classified into A, B, and C. The A waves are nothing but the severe increase in the intracranial pressures. When you monitor, you see over a period of 30 minutes, if the ICP is successfully higher around 60 millimeters of mercury, this is the trend graph which needs a urgent treatment. Anything more than this 50 to 100 millimeters of mercury for more than 10 minutes indicates decompensation. It needs to be treated. There are Lundberg B waves, which are rhythmic oscillations with peak increase in the intracranial pressure every 1 to 2 minutes. Unless they are sustained, we need not worry much for the treatment. So these are the summary of the Lundberg A waves. You can see the trend here. Anything more than 50 minutes of mercury like this, or anything which is sustained Lundberg A waves, which is more than 22 millimeters of mercury for more than 5 to 10 minutes, it needs a urgent treatment. So what are the different types of ICP, invasive ICP monitor? I said as before, they are either pressure transducer or the fluid coupled devices. The pressure transducers is that they are a stained glass type or a fiber optic technology which they use. I'll come back to it. And the fluid coupled devices, as I said initially now, that you put a catheter in the intraventricular space and you connect it to an external stained glass, like how we connect it to our routine arterial lines. So these are the different types of ICP monitoring devices. I already covered this. So currently used best methods of ICP monitoring are either you place a catheter in the intraventricular space or the microchip transducers. So when you place this inside, there is a chip at the distal horn, which actually measures and transmits to the monitor where you monitor the ICP. So intraventricular catheter is connected to, you see the transducer, pressure transducer, like how we connect, and you get the waveforms. This is the intraventricular catheter monitoring. This is how you place the catheter inside in the frontal horns of the lateral ventricle. So there are several advantages of intraventricular ICP monitoring because it is most accurate and standard against which new monitors are being calibrated. And the advantage is it can be re-zeroed again and again and recalibrated. And when the ICP you find it high, easily you can drain the CSF to reduce the ICP. The disadvantage is it requires some maintenance, infection, intraparenchymal hemorrhages can happen. The other things are implanted microchip transducers, where you can see at the tip there is a microchip which senses the changes in the pressure and gives a value. Like you can see, this is the monitor which Codman ICP Express, which we commonly use for intraparenchymal sensors. The same sensor can be inserted intraventricularly also, but the only disadvantage is you cannot withdraw the CSF. The advantage is that it is position independent. There is no worrying of zeroing and all, and very less trip. So this can be used efficiently. However, these sensors are costly, around 40 to 50,000. Hence, the intraventricular catheter is the one which is commonly used in India now. So this is the monitoring. You can see here in this patient, it is attached and the ICP is being shown as 42, 41. And when the head end elevation is done, you can see that immediately the ICP reduces to 25, 26 like that. So this is the advantage of head end elevation, and the ICP monitor, when it is there, you can institute these therapies. So having said the ICP monitors which are invasive, there are several non-invasive ICP monitors which are being developed. Though they are under experimental stages and not very clinically useful, the one which is used commonly is the optic nerve sheath diameter. As we know that optic nerve is continued by the subarachnoid space and the CSF and the dura. So you can make out anything, this whole part is called as the optic nerve sheath diameter, which is measured 3 mm behind the globes. In this picture, you can make out this the globe and this the optic nerve. And from 3 mm behind the optic disc, you measure the transverse diameter of the nerve. The cutoff what we take around 0.5, 0.55 based on the researchers, and anything more you can see in this patient, one of the brain dead patients, where when the ICP is high, the optic nerve sheath diameter increases, but it is not quantitative. This test is qualitative, that anything more than 0.5 is indicative of raised ICP, but it will not tell whether it is 20, 30, 40 or 60. So this is one of the qualitative measures which can be used easily in the bedside in the neuro ICU for patients for detecting intracranial hypertension. So what does the actual literature say? There is a trial of intracranial pressure monitoring in traumatic brain injury. And what they did, the study in the multiple ICU of Bolivia and Ecuador, where one group was controlled with ICP monitoring and managed, the other group was as conventional we do, and it did not show any significant mortality benefit. However, the study was hugely criticized all over the world, and in places like America and all, where it's a common practice to use ICP monitor, it was heavily discouraged that ICP monitoring has to be continued, and it should not be based on this study that it should be discontinued. So there are ifs and buts are there for each. But however, when the ICP monitoring is, definitely you can institute much of the therapies earlier, hence leading to improved outcome. So to conclude, raised ICP can increase the morbidity and mortality, as we know already. ICP monitoring and control is very important, and because the earlier you control, the better are the outcome. Intraventricular catheter in India, at least it remains still the most commonly used, and it is the gold standard for ICP monitoring. The only disadvantage of this is that there is a higher risk of infection and obstruction, which you should take care, because it is not like arterial line that you can repeatedly keep on flushing it, because you are flushing inside the techniques in the coming future. Techniques in the coming future.
Thank you, sir, for giving this wonderful talk and very informative. Sir, I only have one question. After the intraventricular catheter, which other method you suggest? if it is not there. Is Prasanna sir there in the?
I think there was some issue with them, so we will move forward.
Okay.
I would request to chairperson please introduce.
Yes. The next lecture is challenging balancing act and the depth of anesthesia and delirium. And I would like to welcome Professor Manikandan sir. He is the professor and head associate and associate dean in the division of neuroanesthesia and critical care in the Department of Anesthesiology, Sri Chitra Institute of Medical Sciences and Technology. He has an experience of 24 years of neuroanesthesia, and he has a special interest in patient safety and neuromonitoring. He has more than 80 publications and 6 books chapter written. Thank you so much. Welcome, sir, for your talk.
Morning to all. At the outset, I would like to thank the organizing committee of ISNAC 2021 for giving me the opportunity for this very important problem, that is about the anesthesia and its effects on the generation of delirium, its process and management. So I'll be dealing this talk based upon the background, incidence of delirium in the perioperative period, what are the various definitions, how it is different from postoperative cognitive dysfunction, what are the impact effects of anesthesia, and some of the guidelines which has come in the recent years. When we give normally the anesthesia in our day-to-day practice, we generally look at the anesthetic depth in terms of we want to avoid awareness in the patients. We at the same time we want to avoid movement of the patient, and we have to give a pain-free perioperative period. And almost every one of us will know that early awakening is one of the key. At the end of surgery, patient should be fully awake. There should not be any residual action of any anesthetic agent. So this is how we balance our anesthetic techniques day in, day out. So what happens currently is that what is the problem which we face by doing this routinely? The background is the postoperative cognitive dysfunction was recognized 3 decades ago. The first international study of postoperative cognitive dysfunction came out with the publication in Lancet 1998. They found that almost 26% of the people who are undergoing major surgery were having postoperative delirium, whereas a control in UK is around 3.4%. It was found is a multicentric trial across Europe. So there was similar incidents across the Europe. And when they analyzed the risk factors, we found that increasing age and duration of anesthesia is one of the strong predisposing factor for the development of postoperative delirium and cognitive dysfunctions. At the same time, they also noted intraoperative hypoxemia and hypotension were not significant risk factors. So after 25 years, what do we have right now? This is the latest article which has come in November 2021. The risk factors has enlarged from only the advancing age. As you look at that, advancing age is still present. Many other risk factors have been added to the list of VOD development that include dementia. It's a very strong predictor, also outcome of almost 24%, 24. Then we have multiple comorbid conditions like hypertension, diabetes, stroke, pre-operative psychiatric illness. And one of the most important thing which we should take consideration is the use of sedative and hypnotics in the intraoperative period. Odds ratio of around 6.4. So other my minimal or minor risk factors includes a preoperative hemoglobin level and a low preoperative mini mental examination score. So incidence last 20 years, it has not changed much. It depends upon the different type of surgery. Patient with abdominal surgery, vascular surgery, or coronary cardiovascular surgery has got a higher risk of post-operative delirium compared to superficial surgeries. The range vary from 10 to 50%. So why POD is of major concern for us, even though we are not directly involved in the management. What is more alarming or relevant in this situation is this data from Australia. What was found that individuals with more than 60 years receive 1/3 of anesthetics, more common than any other age group, and they represent only 14% of the population. By 2050, they will comprise 25% of all the population, and they receive 50% of the anesthetic agents. So if you look at that, 50% of these patients will have postoperative delirium is a very big number. This is a similar situation in India. By 2030, India will have the largest population of old age in the world. So there is increasing aging population happening throughout the world, and then they are having more comorbid conditions. They have more disease process, they require more surgeries, and obviously the patient may have more postoperative delirium and cognitive dysfunction. Another important thing about the postoperative delirium is this is now considered as a public health priority across all in the Europe, Australia, as well as in US. The European Society of Anesthesiologists has come out with the recent guidelines. As a committee was constituted in 2014, and they come out with the guidelines in 2017 for the reduction of postoperative delirium. They found it's a topic of major interest. So, a definition of POD. Delirium is considered to be an acute fluctuating alteration of mental state of reduced awareness and disturbance of attention. So we have to differentiate when you talk about delirium as anesthesiologist point of view, two things. One is postoperative delirium. Normally it occurs in, say, the patient hospital. It occurs up to 1 week commonly. It starts usually after the recovery from the anesthetics are done. So it can persist for up to 1 week, or it can persist up to discharge of the patient, whichever occurs first. What is meant by emergent delirium? Emergent delirium occurs much more common. It occurs in pediatric age group, much common, almost like 70 to 80% of the people. And old age also is one of the risk factors for emergent delirium. It occurs immediately after, in the post-anesthesia period, after extubation of the patient or at the arrival to the recovery room. Once the recovery is complete, recovery of the patient from anesthesia is complete, then it is more likely to be a post-operative delirium than the emergent delirium. What are the concerns of VOD or POCD? This is well narrated by this article which came in September 2019 in Anesthesiology. So there is minor difference in the early period and the early postoperative period between POD, that is postoperative delirium, postoperative cognitive dysfunction. There is always an overlap, as you can see that. This overlap is persistent till 1 month of surgery. As the month goes by, the subtle difference between the POD and POCD develops, and by 12 months, there's most of the patients will have POCD rather than the POD. So as I already informed, one of the concern is increasing number of patients with old age, with severe comorbid conditions. What does this POD do for the patients? So postoperative delirium is associated with increased duration of hospitalization, decreased functional status, postoperative cognitive decline, and one of the more key concern is prevention of the postoperative delirium. How does anesthesia or surgery causes postoperative delirium? It is not only truly the anesthetic drugs or anesthetic techniques, or it can be associated. Surgery also can be a contributing factor for the development of postoperative delirium. Various hypotheses have been postulated. Surgery causes peripheral inflammation. The inflammatory mediators will be it will be circulate in the circulation, it will go to the brain, there will be disruption of blood-brain barrier. This where the anesthetic agents come into play. If you give general anesthesia, general anesthetic drugs are neurotoxic in vulnerable patients, especially in the developmental age as well as in the old age population. They can cause a disruption of blood-brain barrier and causes entry of various inflammatory cytokines into the brain and cause altered neurotransmitter balance, like between the glycine and glutamine and NMDA receptors. So this stimulates the neuroinflammation, microglial activation, and the apoptosis and cell death in the brain. This is how various postulation mechanisms occurs for the development of POD as well as POCD. So now we have to come whether anesthetic has got a direct impact on the POD. There is no direct evidence on cause-effect relationship. There is no proven studies which show that anesthetics directly causes postoperative delirium or postoperative cognitive dysfunctions. This is one of the article which has it's a meta-analysis which came in 2013. So this is article looked into what are the different strategies for prevention of postoperative cognitive dysfunction. As you see in this, patients who had undergone surgery either in the neuraxial block or general anesthesia, there was no difference in the incidence of POD. Similarly, with regard to analgesic regime, intravenous analgesia versus epidural analgesia, again, there is no difference in the incidence of POD. One of the key finding which has come out in this, dexmedetomidine has got a favorable profile for reducing the incidence of POD compared to other sedative agents. In addition, the study also found that various antipsychotics, especially haloperidol, can help in preventing the delirium in the postoperative period. Coming to a very recent articles which has come in Journal of Medicine in 2021, this authors it's a meta-analysis. The authors have studied the effects of perioperative interventions in preventing the postoperative delirium. It's a meta-analysis of more than 3,000 articles. Finally, they have come out with 63 randomized control trials were properly analyzed. Their findings are fast-track surgeries. If you do a fast-track surgery, it permits the early recovery. It has resulted in the lower incidence of postoperative delirium compared to the conventional surgery group. Almost you can see that 3.4 versus 13% almost. Again, this group did not find a difference between either the use of regional anesthesia or general anesthesia in the incidence of delirium. Again, some few studies have noted that propofol would have a favorable outcome in postoperative delirium compared to sevoflurane or desflurane, but this study which did not find any difference in the incidence of POD between intravenous as well as inhalation anesthetic agents. Coming to the peri-procedural sedations, many of the anesthetists will give sedation during a regional anesthesia, especially in old age. So peri-procedural sedation, we did not find any difference whether you give a lighter sedation with a BIS value of more than 80 or deep sedation at BIS value of 50. Peri-procedural sedation in regional anesthesia did not have any impact on the incidence of POD. The incidence was more or less same. Again, this article also found that perioperative use of alpha-2 agonist receptors, especially dexmedetomidine, caused a reduction in the postoperative delirium, both in cardiac surgery as well as in the non-cardiac surgery groups. One more important finding is multimodal interventions and analgesia, especially non-opioid based analgesia, can reduce the incidence of POD in the perioperative period. Other intervention which increase the incidence of POD in these patients include tight glucose. When these authors found that tight glucose versus liberal glucose, tight glucose patients had a more POD compared to the liberal glucose group. And again, perioperative use of various typical and atypical antipsychotics like haloperidol, olanzapine, and other drugs reduced the incidence of postoperative delirium in these patients. What is the role of BIS? Now we come to the topic whether depth of anesthesia makes an impact in the development of postoperative delirium. This is a study which was done, which has come Cochrane database review in 2018. They have analyzed the use of processed EEG and evoked potential techniques on the incidence of reduction in the postoperative delirium. They founded 6 randomized control study trials with almost like 3,000 patients were included in the study. They found that there is a moderate quality of evidence that BIS-guided and optimized anesthesia guided by processed EEG, especially bispectral index, could reduce the incidence of postoperative delirium in vulnerable people, that is, patients more than 60 years or over, in both cardiac surgical and non-cardiac surgical procedures of the patients. The most important disadvantages these studies include, they are all non-blinded studies. The protocols of management were not found to be very strict in this. They are all low quality studies, but the quality of evidence is, when you use the EEG based techniques, there could be a reduction in the incidence of postoperative delirium. Again, the study which came in July 2021, the same study which I had already quoted, this study did not find any advantage of using NIRS or EEG based techniques, processed EEG, for reduction in the POD. However, what they found, there was a tendency, if you use a BIS titrated anesthesia with a BIS value of 35 versus 50, so BIS titrated to 50 reduced the incidence of POD compared to a deeper plane like 35. So as you see this forest plot, there is almost like 0.7 odds ratio. If you use the BIS, there is a slight favorable improvement in the reduction in development of POD. However, these studies were refuted by the next 2 studies which I am going to discuss. This is a very famous study, the Engages randomized clinical trial which came in Java 2019. What they have found, they have randomized 1232 patients with the age of more than 65 in patients who are undergoing major surgery receiving general anesthesia. They are randomized into 2 groups. One is BIS-based anesthetic administration, and then other group is conventional anesthetic techniques. All the patients had a BIS monitoring, but the conventional group had a blinded towards the BIS. The primary outcome was incidence of delirium between postoperative day 1 to 5. As you look at this, the overall delirium incidence between the patients with the BIS-guided versus usual without use of BIS were found to be same in this study. One of the most important finding, ancillary finding, is patients who are used conventional had a low incidence of intraoperative patient movements, whereas patients who are bit wanted using BIS, anesthetic titration using BIS, there was high incidence of intraoperative patient movements. Another important point of the study is, if you look at this, there is high mortality in patients who are having conventional group versus use of BIS reduce the perioperative mortality in these groups. This is unexpected finding in these groups. For overall, the primary outcome, the comparison of incidence of delirium was similar in BIS-guided as well as conventional anesthetic groups. In conventional anesthesia groups, the BIS was kept around 40. So that is one of the drawback which has been quoted by other studies quoting this study. This is one of the newer study which is yet to be published. It is to be published in December 2021. That's a short randomized control trial where patients undergoing elective hip surgeries were randomized to receive either general anesthesia or spinal anesthesia with the targeted sedation. The spinal anesthesia group had a targeted sedation with the BIS of 60, whereas general anesthesia BIS was applied, but the anesthesiologist was blinded to the values of BIS. As you see that the BIS was less than 40 in most of the patients under general who were blinded, whereas BIS was kept above 55 in patients who were undergone surgery in the spinal anesthesia group. But this is what is more important for this. So incidence of delirium did not differ between these 2 groups. As you see that spinal anesthesia BIS monitor, as you look at that, they had slightly more percentage of postoperative delirium compared to the conventional general anesthesia with masked BIS. So Both the studies have refuted the claim that depth of anesthesia monitoring really helps in reducing the incidence of postoperative delirium. So now we are left with what are the options. So our anesthetic drugs did not impact the incidence of postoperative delirium. Depth of monitoring also does not impact the incidence of postoperative delirium. Now we have to look for the other ways. So how do you manage these patients? So patients who are at risk for postoperative delirium, it is important for us to reduce the incidence. This is an article from 2018 Journal of Neurosurgery Spine. So they also advise a cognitive impairment assessment should be considered in the perioperative evaluation of elderly patients prior to surgery. This is coming in a big way in the PAC. All the patients who are vulnerable, you have to identify the patients who can develop postoperative cognitive dysfunctions as well as POCD. So how do you manage these patients? So there are 3 articles which gave some guidelines in reducing the risk of postoperative cognitive dysfunction as well as the delirium. One is this ECASH. ECASH means early comfort using analgesia, minimal use of sedatives and maximal human care. So this is the article came into intensive care where they target patient should be comfortable and cooperative, which means patient should be pain-free, patient should be maintaining the adequate sleep, patient should not have undue lines like intravenous lines, early removal of urinary catheters, use of multimodal analgesias and opioid sparing adjuvants like dexmedetomidine can help much better in reducing the POD. Then if your patient requires sedation in the ICU, avoid deep sedations and titrate this sedation to specific goals using various scales which are available in the literature. Again, early mobilizations, sleep promotion, and then there should not be prevention of excessive noise or visual problems which can affect the outcome of the patients in the intensive care. And more family engagement is needed in improving the postoperative management of these patients. So this is a narrative in which came in Journal of Anesthesiology, Journal of Neurosurgical Anesthesiology on how to improve the outcome, especially cognitive outcome in elderly patients. Their advice is add anesthesia in making decision about, whether you require surgery or not, what type of surgery required, when you have to proceed for surgery. That should be one of the important goals. And they also advise to minimize the anesthetic depth and then avoid periods of EEG burst suppression. This is of anesthesia. Undue fluctuations in anesthesia avoided, and limit the duration of continuous anesthesia wherever possible. Consider the possibility that regional anesthesia with deep sedation may be a neurotoxic as equal to the general anesthesia. Try to avoid deeper sedation, especially when you are using a regional anesthesia basis. When feasible, use regional anesthesia with advice or indications which have been given by Dr. Cottrell. EJA has found that POD as a topic of interest. They have advised to evaluate for the risk factors. The risk factors could be preoperative, intraoperative, and postoperative. What they have mentioned is age, ASA status, comorbid condition like diabetes and hypertension, stroke, anemia, use of drugs, alcohol. Then they also try to avoid prolonged fasting. Prolonged fasting can produce hypoglycemia. It also increases the risk of POD. Hypo or hypernatremia also increases the risk of POD. So try to avoid, evaluate, and then try to minimize it or try to manage in the preoperative period. Intraoperatively, site of surgery, certain surgeries like ENT surgery, abdominal surgery, cardiac surgeries are at high risk for developing POD. So you should have some amount of prophylaxis and proper plan of management in preventing POD in these kind of patients. Again, intraoperative bleeding and duration of surgery also should be taken into consideration when you are trying to prevent the POD. Postoperative pain and patient comfort is to be maximized to the best. So perioperative use of anticholinergic agents and benzodiazepine should be avoided to reduce the incidence of POD. whenever possible, use alpha-2 agonists like dexmedetomidine. Dexmedetomidine has a more favorable profile compared to the clonidine. Then try to reduce the surgical stress in the perioperative period by use of neuromonitoring to avoid excessive deep anesthesia. Try to effect multimodal opioid sparing analgesia, and then implement enhanced recovery programs to reduce the incidence of POD. Our sedation targets: avoid BIS below 40. BIS below 40 is considered to be a deeper anesthesia. Try to keep the BIS of 50 to 60 and avoid bus suppression. Try to maintain a steady state anesthesia rather than giving bolus dose of drugs. If you want to use a sedation, so recommended sedation score is Richmond agitation sedation score. Either -1 or -2 should be a good goal in maintaining the plane of sedation if you are trying to give a sedation in the ICU and in the perioperative period. So protocol should be kept in the OT as well as in the ICU. Post-operative monitoring aim to early detection of post-operative cognitive decline as well as post-operative delirium should be there. It should be present till the patient is discharged from the hospital, because POD can occur at any time in the hospital. So to conclude, this article, which came in 2009, has clearly mentioned that considering that there are no alternatives to the available anesthetic drugs in most cases, it becomes incumbent on anesthesiologists and intensivists to use the existing drugs judiciously while developing ways to minimize the potential for harm. So we cannot avoid the anesthetic agents, but try to use a minimal dose and use it judiciously. So that's how you can reduce the prevent the complication, as well as reduce the incidence of POD in these patients. Thank you so much.
Thank you, sir, for the very informative lecture. Sir, I have a question. It is my question that to evaluate the cognitive impairment, especially in the elderly patients, which test or questionnaire should be the most appropriate one, so that we can predict it beforehand?
Dr. Manikandan, are you there? Dr. Manikandan, are you there? Dr. Ruchi, I think Dr. Manikandan hasn't joined.
Okay.
Should I start the next?
Yes, for sure. Our next speaker is Dr. Ajay Prasad Hirshi. He is the Associate Professor of Neuroanesthesia and Critical Care at Sri Chitra Institute of Medical Sciences. He has a special interest in TIVA in neuroanesthesia, awake craniotomy, T in neuroanesthesia, neurocritical care, intraoperative neuromonitoring. And he also awarded with the ISA Young Anesthesiologist Award, Isacon Kerala 2018. He also awarded with the COPS Award for the best paper in neuroanesthesia, Isacon 2015 Jaipur. And he also got first prize in presentation at the annual perioperative TE and critical care conference, PGI-MER. He has many publications also. So welcome, Dr. Ajay, for your presentation.
Good afternoon, everyone. Warm greetings from Sri Chitra Tirunal Institute, Trivandrum.
First of all, I would like to thank the organizing committee of Isacon 2021 for organizing such a wonderful hybrid conference. Now coming to the topic, it's controversies in neuroanesthesia. The topic is albumin in brain injured patients. I'll be talking in favor of albumin. Next, let's explore where all albumin is currently being used. Albumin, as we all know, has been broadly and extensively being used over the last few years basically as a natural replacement fluid to correct the intravascular hypovolemia and to correct the hypoalbuminemia. The current indications with evidence are like spontaneous bacterial, hepatorenal syndrome, large plasmapheresis, which is mostly mediated especially. Next, coming to the neuro setting, there has been a lot of trials which explored albumin in neurocritical care. First, coming to the Isacon trial, that is the use of albumin in subarachnoid hemorrhage. And this unfortunately, the recruitment was terminated because of two adverse events. Patient reaches of 1.8. What is noteworthy is that albumin doses up to 1.25 grams per kg per day was well tolerated in patients with acute subarachnoid hemorrhage without major complications. A follow-up analysis of these patients demonstrated that the patients who received higher concentration doses of albumin had in fact better neurological outcome, even though it couldn't be proven statistically because of the underpowered study. And this was evidenced by a reduced incidence or delayed incidence of delayed cerebral ischemia, reduced incidence of vasospasm, as well as cerebral infarctions as noted in CT scan. So this led to the Isacon-2, that is a phase 3 randomized controlled trial, which is happening currently with 25% albumin at the dose of 1.25 gram per kg per day for 7 days. Let's hope that that will shed more light into this subset of population and how good albumin brings out in these scenarios. Next, coming to the Achieve trial. Achieve trial was a study where they examined the potential neuroprotective benefits of albumin in the setting of non-traumatic intracranial hemorrhage. In this trial, the patients were set to receive 3 daily IV infusions of 1.25 gram per kg of 25% albumin for the first 3 days following enrollment. Again, unfortunately, the study was terminated, but this time due to non-clinical reasons as the PI got transferred to another institution. However, what is noteworthy is that there were no adverse events reported in the recruited population, which gives some hope to the further trials to happen in this subset of population. Now coming to the mother of all these trials, which prompted the use of albumin in intensive care unit, is a SAFE trial, that is the albumin versus saline for fluid resuscitation in intensive care unit. The SAFE trial concluded that there was similar outcomes at 28 days in the population, either whether they were resuscitated with 4% albumin or normal saline. But what caused a lot of negative perception for albumin in the neurologically injured patients was the SAFE TBI study, which was in fact a post hoc follow-up analysis of patients who were neurologically injured after traumatic brain injury and who were a part of the SAFE trial. In this post hoc analysis, they identified that the 2-year mortality was significantly higher in the TBI subgroup as compared to the saline, and the majority of the deaths occurred within the first 28 days. But it is important to note that the difference in mortality was observed in the severely brain injured patients with a GCS of 3 to 8 and not in the ones who were presenting with a GCS of 9 to 12 or higher. So what could have led to this increased mortality in this subset? James Cooper et al., they evaluated the data and they found that, in fact, the people who this population who was recruited in the SAFE TBI trial, what happened is they had a mean ICP which was higher in the albumin group as compared to that of saline. And unfortunately, they monitored the ICP only for the first week. And what was found that the mean ICP was significantly higher in the albumin group. And as you can see, the dead population had really high ICPs as compared to that of saline group. So they hypothesized what could have led to the increased ICP. One is that, which is most important finding, is that the albumin preparation which was used in the SAFE study was in fact hypotonic, and which was even lesser than that of 0.9% saline. So this could have led to increase in cerebral edema and raised ICP. The other physiological explanation could be the leakage of albumin because of the disrupted brain barrier, leading to increased interstitial colloid oncotic pressure and thereby increasing the ICP. So they suggested that it's prudent to avoid albumin for fluid resuscitation in these subset of population, especially for the first week after a traumatic brain injury. Now coming to an animal study, which happened after the SAFE TBI, they evaluated again albumin versus crystalloid on a rat brain, which was a model, and they simulated a traumatic brain injury. And they found that given the same volume, isotonic crystalloids caused more post-traumatic brain edema than 5% albumin at 3 and 24 hours after trauma. And what is also has to be noted is that at 24 hours, the albumin cohort had actually less edema than the two crystalloid groups versus which it was compared. So this might give some support to use of albumin, at least a higher concentration of albumin in non-TBI craniotomy, especially for tumor resection or even in TBI population in the future. So what's limiting the trials from happening? It's mainly the potential harm which everybody is scared, that is the pulmonary edema and coagulopathy. What we need to learn from the previous trials is it is the higher doses, that is more than 1.25 grams per kg per day, that resulted in pulmonary edema. So this has prompted the trials such as the ALISA-2 to use a lower dose of albumin. But the other one which is of relevance to us is the coagulopathy, especially in the combination of a mannitol. It is found to cause impaired blood coagulation and platelet function. So it might be prudent to avoid albumin trials in patients who are receiving mannitol. And again, the cost effectiveness, as we all know, it's 100-fold more expensive than a crystalloid. So that could also be limiting the trials from happening. So what to do when we plan for future trials is to identify the optimum dose and concentration. I think the ALISA-2 trial group has identified the optimum dose. That might be the 1.25 gram per kg per day of 25% albumin. And also, more importantly, to identify the cohort of brain injured patients who might benefit from albumin, namely brain tumor surgeries, subarachnoid hemorrhage, as well as non-traumatic ICH. And it's very important to avoid low concentration 4% albumin in scenarios such as traumatic brain injury and also in neuro settings, because it itself will, any hypotonic solution, including ringalactate, is going to cause cerebral edema. And avoid albumin in scenarios where mannitol is being used. So to conclude, each brain injured scenario is a heterogeneous group of processes. So it's quite difficult to pinpoint the outcome benefit on an IV solution. As of now, it's really difficult to find any definitive data to either support or dissuade the use of albumin. at least in the non-TBI population. So the clinician should consider the potential benefits and risks in a case-based scenario and optimize the treatment for their patients. Thank you.
Thank you for the presentation, Dr. Ajay. I think we should move upon the cons part also, and then we can go for the discussion.
Dr. Ajay, are you there? Dr. Ajay? Ma'am, I think Dr. Ajay is not also.
Okay, then we can go for the next one.
What's the last
cons
question?
part.
We can conclude the session now.
Okay, thank you. Is there any other lecture of Dr. Srilata on cons part of this session, the albumin and brain injured patient?
Just give me 1 second, ma'am. I'll check. No, ma'am, we haven't received anything from Dr. Srilata.
Okay, then thank you so much for giving me the opportunity to take part in this conference. Thank you, the organizing committee. I think I can leave the session now.
Yes, ma'am.
Thank you so much.
Consider that your delivery is daily stationary. They won't be looking at stepping out with the fear of missing it. Amongst the diaper is stationary, you can line them up. Nice boy! He's going to put here. He might have a silly point. More going towards the offside. This is going to be the last over before the tea break. Must be really happy with the innings so far. New Zealand about 68 without loss. Another ball to go. Finishes off in style in session. Should find the boundary. And he does. With another boundary, moves to 46 million. And at the end of the second session of day 2, New Zealand fighting back stronger. With a very impressive reply of 72 without loss after India got to 345 in their first innings. Glorious shot this. An excellent placement. Keep on the drive, pivots in the air, the boundary as well. Aggressively the full piece of the bat. Good stretch forward, transfer body weight, copybook shot. 46 beyond 7 boundaries. In partnership 78. 72, beg your pardon. Overall, this session, India lost a couple of wickets. 28.1 overs bowled this session. 2 wickets, and those 2 were Indian wickets. 78-72 coming in this innings of New Zealand. Only bowled by the spinners this session. But what a session as far as New Zealand is concerned. That's the Indian batting card. Sashmita played a very good hand of 38 before he was rolled by Majad the third. Ishal projected at the India's account. 45, but India were all out close by that century of debut by Shreyas Iyer. Half century by Jerry as well. And there is the New Zealand reply. 72 without loss. Young in particular has looked very good, as was evident from that last shot. Last ball before he went towards the pitch of the ball, big striding forward, leading into the drive. Looking very comfortable. And it gives an opening there. 72 without loss. India using 5 bowlers. None of them really making any impression on the batsman. Yes, there has been the odd close shave as you would expect. But no real alarms. And so, good tea time for New Zealand. 72 state 1 and 72 here. Another session which goes New Zealand's rate speed and New Zealand day so far, day 2. They won 3 out of the 5 sessions so far. We'll take a short break and we'll be back soon. But before that, have a look at the highlights so far. India ended with 345 runs on the board and it was only the half with Young. They do everything at them from the overs, but defiant and stood their ground, ending the session with 72 runs on the board, only for the team without losing any wicket. But a session has been going on here, led to by the cricket line, and the studio are going to depart for Bharat and from the rebound to give you a good sign and do. Harvard drops the wicket and they managed to restrict India to down under 350. Well, they're very happy and so on their teammates. How much is a cup of tea, Dave? Hey, where you going to the game? Okay, it's been a really good thing. Obviously, they needed to top up those 2 wickets quickly if they could. They just got into the act, which was the right thing. And just found a little bit of tune out of the actually, a little bit unlucky, but the certainly combination is fantastic. We know how good Tom played with a lot of confidence. And Kim, go back to the surface though, it hasn't played any tricks as yet. It's been low, it's been slow. We haven't really seen a lot of turn unless it's hit a foot mark or two. So it is still pretty good for batting on, and New Zealand need to make the most of this great start. If cricket falls, new batsmen come in, ball gets slightly over, and if the ball starting to go slightly, that's where I want to see what kind of field it comes up. So far, they were really well, but the challenge is stability. But it's a strong New Zealand that has turned out in the form of Completion and India. Now, India started with Brits, Isacon and Isacon, set up a pace, and then they started with the spinner, Ravichandran Ashwin in demand. Maybe they were something to spin on this pitch. So I don't think so. I think they should have started with that. With the wicket part, some wicket swing, big challenge for any young owner to come and back on these services. He's had a lot of first class games, but he's just been tremendous. Getting 43, there's the and a couple of moments in the goal playing this is from the YouTube and what I've just seen there. But the way he is taking to the spin and being quite aggressive when the opportunity presented itself. The great use of the feet, the way he's got back in the street, the way he's come down to it as well. That's the sign of last ball 14. Right is the way for him to cover. Any scoring opportunity, just matter with last ball 14, they were trying to get in it and be done down. He still had an opportunity, so he put it away. And to me, that's a sign of a fairly confident guy.
Hello, sir. Am I audible, sir?
Yes.
So we can start the session now.
Yeah.
हाँ हो गया आ गया
Dr. Mohan, please introduce Dr. Mohan.
Yeah, already the recording is there. Introduction is also started. So Dr. Rahul Yadav and myself are moderators, and there is a recording. You can start playing it.
Shall I play the video, sir?
Yeah, video
Yes,
is already
yes,
included
please.
with the recording of introduction.
Okay.
Welcome, dear members of ISA, and thank you, the organizing committee, for giving us opportunity, myself and Dr. Rahul Yadav as moderator, and the rest of the esteemed members as a panelist.
At the outset, I would like to thank the organizing committee for giving us this opportunity to share our views with the esteemed audience. The topic which has been given to us for the panel discussion is really important. There is fluid replacement in neurosurgery. So now, to take forward this topic, I've got my fellow moderator with me, Dr. Mohan Maharaj. Dr. Mohan Maharaj is a well-known anesthesiologist and intensivist from Vizag, Visakhapatnam. He is the head of modern anesthesia services and director of critical care medical hospitals. He was the IAC secretary and president of the Visakhapatnam branch. He is very fond of conducting the life-saving courses. He is a DNB IDCCN teacher and examiner. He has multiple national and international publications to his credit, and he has been a regular speaker at the IAC National Conference since last 6 years. So Dr. Mohan Maharaj is my fellow moderator. Now, it's my honor to introduce the panelists. To begin with the senior most member, Dr. Shashi Srivastav. Her name is very familiar to all of us. She personifies woman power in Indian Society of Neuroanesthesia and Critical Care. She is a professor anesthesiology and unit in charge of Division of Neuroanesthesiology as a SGPGI Lucknow. She has been the past president of Indian Society of Neuroanesthesia and Critical Care. She has been the she is the president of the first president of the Neurocritical Society of India, as well as the past president of Lucknow ISA. She is a regular speaker at various national and international meets, and she has been one of the leading lights for neuroanesthesia in this country. Coming to the other panelist, Dr. Punaiya. Dr. Punaiya is the dynamic neuroanesthesiologist and neurointensivist who has taken the society to greater heights. He's serving as a secretary for the ISNEC, and he has been single-handedly responsible for revolutionizing the academic scenario for the society and taking the society to greater heights. He is presently working as director and head neuroanesthesia and neurocritical care at the NGM Group of Hospitals, Chennai. And he is a regular speaker at the national. He's actually not only regular, he's much wanted, much sought after speaker for all various national and international conferences. So Navdeep is additional professor at AIMS New Delhi. He is one of the course director for the acute critical care course, as well as his workshop on cadaveric workshop on airway has been the first of its kind in this country. He has got 39 publications to his credit, and he is still a keen learner. So over to you, Dr. Mohan.
Sir, it's very nice and it's a good opportunity. And as you said rightly, I thank the organizing committee for giving opportunity for us to do this talk and panel discussion with esteemed people like you people. And yeah, just to say, Dr. Rahul Yadav sir has introduced a few panelists, and now he is a man who is really heading one of the biggest hospitals of Navi hospitals in India. That's in Mumbai, Ashwini Hospital. Everyone is aware of it because everybody would like to get treated there in the hospital from any Navi member, because whenever I meet here, they tell that. So he is a professor and HOD of anesthesiology and neuroanesthesiology. And he's actually, the area of interest is particularly is very good in neuroanesthesia and pain medicine, emergency medicine. And one important thing I would like to specify is that he conferred with the prestigious Bharat Vikas Award in 2019. That's one of the important points where we think really is appreciable for him. And he has 28 publications for his credit. And he's an editor of Journal Club for ISNAC, Indian Society of Neuroanesthesia and Critical Care. Also, he is an editor and peer reviewer of various reputed journals from the specialty of anesthesia and critical care and neuroanesthesiology. And actually, he is nominated as a convener for specialist board in neuroanesthesia and critical care by National Board of Examinations and the first neuroanesthesiologist of Indian Navy. So, congratulations, sir. And the first neuroanesthesiologist of Indian Armed Forces to do a DM. And he's the first Armed Forces medical officer to be awarded a fellowship in International Medical Sciences Academy at Royal College of Physicians and Surgeons in Glasgow, and a fellowship of Academic College of Emergency Experts. So at the same time, one of his junior colleague who has been fond and telling about that how he is good in academics in his own, when he was a student, my colleague was talking about him. I'm very happy to be getting shared with this panel, very nice. And coming to the other panelists, what we have, the esteemed people are like Dr. Ankur Luthra. So he's actually a man who's working in PGI, and he actually has done he's DM neuroanesthesia from the AIMS New Delhi, and he is doing in PGI Chandigarh now, and he's a member of a lot of societies like USA Neuroanesthesia Society and Indian Society and Neuro Society, ICA and NCS. So all these neuro societies he is member of it, and he is affiliated to it. His experience is particularly neurocritical care and pediatric and trauma care and difficult airway scenarios. Is very experienced and clinical interest. He has an expertise in that. And also, he is good in awake craniotomy, pediatric brain tumors, and spine surgeries and neuromonitoring. It's very nice, sir. Very nice to know. And he actually have 5 international and publications, including 17 international book chapters. Very nice of you, sir. And really, I'm very delighted to introduce and tell about our another panelist, Dr. Jaya Wanshu, and who is actually graduation from Rohtak, and she has done DNB anesthesia from Jaipur, and she has 20 years of experience in Apollo Delhi and Fortis Bangalore. Very senior, ma'am. And currently working as associate director at Medanta Hospital, Delhi. I think Delhi, I'm sure, ma'am. And affiliations member of ISNAC, ISCM, and Society of Neurocritical Care. And her areas of interest includes neuromonitoring in ICU and using ultrasound guided, and particularly AIM in ICU and brain death and organ donation. These are important areas of interest, and what she is perfect in this. So I'm really thankful, and I request Dr. Rahul Yadav to start our panel discussion.
Thank you, Dr. Mohan. So now every test of whether neurocritical care, neuroanesthesia starts with talk about blood-brain barrier. Definitely, something must be really important about it. So I would take this opportunity to request Dr. Navdeep to throw some more light about the blood-brain barrier and its importance.
Yes, before answering, I will like to thank all the conference organizers. So, blood-brain barrier, the term was coined by Lewandowski in 1898, and blood-brain barrier is a highly selective semi-permeable membrane that is made up of capillary endothelial cells, the basement membrane with embedded pericytes, and the astrocyte feed processes. So, as you see that this is a barrier, but what can pass through this? So, water is freely permeable through this. So that's why we can take the advantage of hyperosmotic agents, so that we can draw water from brain, or water can go inside the brain also through this barrier. Highly lipid soluble agents, or the drugs, definitely they can cross. But what about glucose and amino acids? Essential amino acids and glucose, they can pass through with the specific transport channels, GLUT1, which are available or present in the capillary endothelial cells. Well, sodium has to bribe it, the barrier. It has to use ATP and sodium potassium ATP channels to cross this. But definitely, this barrier doesn't allow to cross neurotoxins, certain drugs, and pathogens directly from the bloodstream to the brain. So this is the advantage of blood-brain barrier. And definitely, oxygen, carbon dioxide, and volatile acidic gases can freely cross it. But it is present everywhere in the blood, in the brain. No, it is not like that. The circumventricular organs like pineal gland, the pituitary gland, area postrema, and the choroid plexus, they are deficient in the blood-brain barrier. So this is the thing about blood-brain barrier.
Okay, thank you, Dr. Navdeep. So we all agree with you that the blood-brain barrier is a tight membrane which permits movement of water across the osmotic gradient, but molecules have to be either transported with a co-transporter or a transport channel.
Yes, sir.
Yeah, I think after starting with the physiology and the basic anatomy of blood-brain barrier, I think I can request Dr. Ankur, what are actually the determinants of fluid movement between the intravascular space and the brain, if you see the capillaries, sir?
Yes, sir. Thank you very much for the question. So the basic major determinants are the transcapillary hydrostatic gradient, the osmotic or the oncotic gradient, and the relative permeability of the capillary membrane across which they are passing. And the fluid movement is mainly governed by the typical Starling equation, which we have been reading across our MBBS days. That is, the fluid movement depends upon a capillary membrane constant into the hydrostatic pressure of the capillaries plus the oncotic pressure of the interstitium minus the hydrostatic pressure, which is there usually negative in the interstitium, minus the osmotic pressure of the capillary. So in totality, we can say that it is directly proportional to the hydrostatic pressure gradient minus the osmotic pressure gradient across the capillary wall. Now, if we see the peripheral capillaries and other endothelial tissues, like in bowel, in lung, and other organs, so we see that there is this capillary permeability there's a lot of capillary permeability because of the size. If we see at the figure also, it's almost 65 Armstrongs across the interstitial space and the vascular lumen. So water can freely pass. Even the small ionic polar solutes like sodium, potassium chloride, they can pass, but it is only stopping the larger plasma proteins and synthetic colloids. But if we see the blood-brain barrier, as already Dr. Navdeep has told, that it is not only impermeable to larger molecules, but it is even relatively impermeable to many small polar solutes, or they require some ionic channels to pass through. So it contributes lesser to that. So whenever there is this osmotic gradient is created by the administration of hyperosmolar fluids, it will definitely cause the fluids will be drawn out of the brain, the water will be drawn out of the brain, and it will lead to shrinkage of the brain and reduction in ICP. And reverse happens with the hypoosmolar agents, dextrose containing fluids. They will cause accumulation of fluid or cerebral edema. So that's what is all about the physiology of and the factors governing the transport of ions in water.
Very nice, Dr. Ankul. Again, remembering of physiology of MBBS time and in detail, both Navdeep and Ankur has given us a ball rolling start with all the pages. Nice.
Now, the next question I would like to put forward to Dr. Shashi. Ma'am, can you briefly outline the general principles or goals of fluid therapy in neurosurgery before we discuss in detail?
Thank you, Rahul, for it's a very good question, clinical question. After knowing the physiology from our earlier panelists, I would say that fluid management in a perioperative period of a neurosurgical patient, it's quite challenging to a neuroanesthesiologist. Because why it's challenging? Because the most of the patients of intracranial tumors, they are put on diuretic therapy. So because of diuresis, they have electrolyte abnormalities and sometimes they come to us dehydrated. Plus, when you put them on general anesthesia, they are again vasodilated and they again become hypovolemic. And there is sometimes there is excessive blood loss also intraoperatively. There is inadequate secretion of ADH also. So which all these factors, they complicate the homeostasis of a patient, neurosurgical patients. So that results in the need of a very ideal replacement fluid, which should be isoosmolar, does not alter the acid-base balance, and we should also replenish the electrolytes which are lost by the diuretics. Therefore, the goal of fluid therapy is to maintain the normovolemia and in turn maintain the cerebral perfusion pressure and spinal, sometimes in spinal surgery also, spinal perfusion pressure also needs to be maintained. Then we should restore the intravascular volume also in these patients. We should optimize their hemodynamics and we should, in the end, we should maintain their tissue perfusion, their integrity of the function. So these are all the major goals of the fluid therapy in a neurosurgical patient.
Thank you, ma'am. Very rightly said. The chief goal is to maintain normal volumia, to maintain the cell perfusion and cerebral perfusion.
But as you said rightly, ma'am, you importantly given the important topic of cerebral perfusion pressure. And as you said, now I request Dr. Navdeep sir to just, as you know that we have a lot of fluids and a lot of challenges, particularly for PGs. How exactly you will think about which are the various crystalline solutions presently we have? We have a lot of companies coming every new and day. And what is a lactate not recommended in the Ringer's lactate not recommended in neurosurgery?
Sir, as you told that there are n number of solutions, crystalloid solutions available in the market, and these include Ringer lactate, normosaline, this DNS, D5 solutions, and various balanced crystalloid solutions which are available in the market. But I am more interested in answering your second part, that is why RL is not indicated in neurosurgery. So I would like to say that this question is a little bit incomplete. I would say that RL is not indicated for resuscitation. RL is not indicated for resuscitation in neurosurgery. Dr. Rahul, there is some problem, I think.
I'll make them. You tell now, sir. I'll tell them.
Okay, so definitely in the for the resuscitation, the RL is not indicated because of his hypoosmolar nature. And the normal plasma osmolality is 275 to 295 millicoulombs per liter, where the RL is having 275 millicoulombs per liter. In the recent study by 2016 by the Rowell et al., when they use in the pre-hospital setup, when they saw the use of Ringer lactate versus normosaline, and this was not a randomized control trial, but definitely they studied and they found that RL was associated with higher adjusted mortality rate in the TBI patients versus normosaline. But what about intraop setup? Can it be used as a maintenance fluid? Yes, definitely we can use it as maintenance fluid in a recent study at the PGH Chandigarh by Bhagat et al., where they studied 90%, and they found that when they use the normosaline, Ringer lactate, or the combination of both RL plus normosaline, the ICP was same in all those patients. So definitely RL is hypotonic. It should not be used as a resuscitative fluid, but for a maintenance, when you are giving not more than 3 ml per kg, you can use it and along with normal saline, it can be used. It is not going to increase ICP. So I will take rest. Thank you.
Thank you. Thank you for the real explanation.
I would pose the next question to Dr. Shashi ma'am. Ma'am, all of us neuroanesthesists are very fond of normal saline. Normal saline is the darling of neuroanesthesiologists. It is, so my next question is that is it still the gold standard of fluid therapy in neurosurgery as per the latest evidence, ma'am?
Yeah, actually debate is still going on whether normal saline is better or balanced salt solutions are better. So there are a lot of trials which there is one trial which are on children. They also suggested the use of balanced salt solution, which is better. Nice. And there is one another study by Pondicherry people. They also found that using the balanced salt solution, there is a metabolic profile was better, and the serum NGAL levels with normal saline were very low. So they also recommended the use of balanced salt solution. So like this, there are many studies which are preferring the use of balanced salt solution because it will cause less hyperchloremic acidosis and metabolic derangements. But if you say, but because these the people say because these studies they were only observational studies, and that and there is one pro saline group also. They said that this acidosis is benign in nature and self-limiting, and all the studies which favor saline were having inconsistent results, and they were observational studies. So there are certain prerequisites with normal saline to develop you call acute kidney injury and metabolic derangements. If you are giving these saline to a patient, a very large volume you are giving. Like when we see we are having surgeries of 6 to 8 hours duration, and in these surgeries, if you are giving only normal saline, then definitely you will have the hyperchloremic acidosis. And in our practical use also we see all these things we have, but definitely if the patient's renal function is okay, normal, then I don't think there is any problem with using normal saline. And the rate of infusion also is another factor which determines whether there will be metabolic derangements and kidney injury with saline group. So still there is many authors still there are studies going on, and authors are loggerheads to find the better solution for gold standard solution, is saline or not. So in summarize, administration is of saline and balanced salt solution is equivocal and equitorgines. And in patients not having previous renal disease and we are not giving rapid infusion for a long time, then I think we can use normal saline also. And it is a time-tested practice with normal saline. So I think it's equivocal results with saline and balanced salt solutions. It depends on many factors. You can't say saline is better or salt solutions are better. Nowadays in our practice, we have started using alternate saline and balanced salt solutions in our intracranial cases where we are having 6 to 8 hours of surgery. So that is actually just of our opinion in this.
Thank you, ma'am. Well said. So, in presence of normal renal functions, it's quite safe to use the normal saline. It is time-tested crystalloid, and as Navdeep had already pointed out, alternating normal saline with zinc lactate would definitely have no deleterious effect on the overall profile of the patient.
As Shashi Madam said, equivocal, I request our Jaya Vanshu Madam to just put a little more importance of what actually the current role of balanced salt solutions.
Thank you, Dr. Mohan. As Dr. Shashi pointed out, it is more of a theoretical concern. We have been using normal saline since ages. But to maintain isotonicity, to maintain the blood flow, the aim is to choose a fluid which is closer to plasma, and balanced salt solution with the osmolarity of 295 is the closest. It has sodium chloride as well as potassium and other electrolytes. Normal saline, on the other hand, has only sodium and chloride, and that too in higher concentrations. So there is a theoretical risk of metabolic acidosis, acute kidney injury, which probably we have seen in a few cases, but is self-limiting. As Dr. Shashi pointed out, it corrects itself with the passage of time. But in our institute, we have made it a point to give balanced salt solution where we are expecting large volumes of resuscitation. So theoretically, these advantages and disadvantages are there, but still both the solutions can be used according to our guidelines, and small volumes we can give normal saline safely.
So Jaya Vanshu madam says that even though time tested normal saline, but balance is better now in the long duration of plasma. Thank you. Levels.
Now, I would request Dr. Ankur to take forward the discussion from here. Now, colloids have been maligned a lot, especially with the VSEP trial, 6S, and the CHEST trial, showing that they increase the incidence of acute kidney injury and incidences of renal replacement therapy. On the other hand, the Christmas and the Crystal trial did not show any significant increase in the acute kidney injury. Whereas now there have been some studies which are showing some usefulness of colloids in subarachnoid SAH cases. So I would like you to throw some light on the present use of colloids. Is there any role in neurosurgery during the perioperative period?
Yes, sir. Thank you very much. It's a very pertinent question. And we have all know what crystalloids are doing, large volume resuscitations particularly. They basically tend to reduce the colloid oncotic pressure. Now, the main advantage of colloid solutions is that they are known to prevent this severe reduction of the colloid oncotic pressure, and hence prevent much of the interstitial edema. Now, there are various task force guidelines like the European Society of Intensive Care Medicine, which have said that in brain injury also, they recommend totally against the use of colloids. That is mostly based on the ICU-based or critical care-based studies, where in the intensive care units, they have seen that as you use colloids, they tend to interfere with coagulation. They tend to have increased incidence of acute kidney injuries, or maybe a higher chance of renal replacement therapy. But as Dr. Rahul has pointed out, that even the 6S trial and the CHEST trial have shown that they have increased incidence of AKI and renal replacement therapies. But Christmas and Crystal trials simply refuted it, and they said that when they compared crystalloids to colloids in critically ill hypovolemic patients, they found no difference in 28-day mortality and the need for renal replacement therapy. Coming back to the perioperative period. Now, intraoperatively, one is definitely SAH. To prevent DCI, you need to maintain some volume. Another thing where I would like to say that the studies are very, very controversial in the fact that not many studies or RCTs clarify or refute even the use of colloids. So we are generally using colloids, particularly of the low molecular weight or the low medium weight or the low degree of substitution, like the tetrastarches or the HES starches. And whenever there is a rapid loss, sudden blood loss in intraoperative, and we are waiting for the blood to come, or because maintaining the hemodynamics is most important rather than what choice of fluids you want to give. And when we give too much of crystalloids, like to maintain almost one particular volume of blood we have to replace, you have to give 3 parts of crystalloids as compared to only 1 part of a colloid. So there the colloid will have definite advantage. It will stay in the intravascular space more. It will prolong, and definitely till the time the major this blood comes, when we actually start the blood, till that time we can tide over the crisis, maintain hemodynamic stability, and can administer colloids. At that time it is not contraindicated, but again with the caution that it has a particular limit up to 20 mils per kg, not exceeding that. Usually we do not exceed more than that, because then they tend to interfere with coagulation. Then they have problems with the renal replacement, I mean this acute kidney injury, etc. So we can administer. It is not that totally contraindicated, but we should use them with caution, and as far as possible try to limit their use. Thank you very much.
Thank you, Dr. Ankul, for throwing light on a very controversial topic. So, it's still early to write off colloids. One has to approach with an open mind, and one has to remember that they are the best agents to maintain the intravascular oncotic pressure.
As our Ankur told, about 20 ml per kg is the one we can still think about it. And I request Dr. Ponaya sir to just tell me what actually is the current consensus on the use of albumin, sir.
So, good evening, everybody. So let's keep it very practical. If I see my practice in the last few years or maybe in a couple of years, I have to think in which patient I have used albumin. So that is the practical take-home message. We hardly use albumin regularly in our day-to-day practice. Yes, in certain cases where albumin is rarely required. I worked in centers where they do large number of liver transplants and they'll end up with a neurological problem. So in those cases, we have used albumin. And we have been studying albumin throughout our PG days and also the super specialty days. And in a year, about 2-3 articles also comes on albumin. But if you see all those articles, all those reviews, all those guidelines do not strongly recommend for albumin. So if you ask me, in practice, the use of albumin as a colloid substitute, as a plasma substitute, is very limited in practice. So hardly I use albumin. Almost I don't use albumin at all.
Very nice, sir. And the issue, I'm very happy to say that I was actually part of a safe study in Australia with John Mayberg for 3 months. I was there at the time. It was very nice illustration. Thank you.
Now, next question I would like to put forward to Dr. Navdeep. Again, a very controversial topic in neuroanesthesia and neurocritical care. That which agent should be preferred for hyperosmolar therapy, hypertonic saline or mannitol? Now, I would say Dr. Navdeep is the ideal person because he has published a trial in recent times in Journal of Clinical Neuroscience exploring this equation only. So over to Dr. Navdeep. Dr. Navdeep, you are not audible.
So this is most favored question in any neuro-related seminars or the conferences. So I would like to say what should be preferred, which is available in your OT or with you, which is available, you can use that because actually, and what is the ease of using? You want to use at a bolus, you want to use infusion. So accordingly, you can decide. Definitely, mannitol should not be used in all those patients who are hypovolemic or hyponatremic. Definitely, you won't be using the mannitol in those patients. But if you go to the evidences, in JNSA 2021, recently a meta-analysis was published where they told that where they conducted a study and saw that enrolled 12 RCTs and 464 patients in this study. And they concluded that, okay, the normal saline can be favored, but we are not having enough incidences to back up our data. Another meta-analysis in 2020, August, by Shi et al., and they include 10 study and 564 patients. They concluded that mannitol and hypertonic saline, they are able to equally decrease ICP, but the ICP reduction potential with the hypertonic saline may last longer, and you may have more favorable cerebral perfusion pressure with hypertonic saline. So this is the latest statement regarding the mannitol versus hypertonic saline. And again, I would like to say that, yes, definitely, there are some data that in pediatric patient, when one solution is not working, you can use another solutions. Like if mannitol is not working, a top of hypertonic saline may work in pediatric patients. This is regarding this thing. So you can choose accordingly what is available with you. There's no one is superior till now, but definitely the studies are favoring hypertonic saline more. Thanks.
Thank you, Dr. Navdeep, for throwing light on a very debatable topic. So we all agree with you that the jury is still out. So one should use whatever one has got, keeping in mind that if the patient is hypovolemic and hyponatremic, hypertonic saline is the way to be.
Let me see that now we have two great ladies in our panel, and both of them are, whether normally the females comes together and give the consensus or they give the controversy answer. Let us understand, because we all know less is more in the concept of recent things and what actually the preferred modality of restrict to our liberal fluid therapy. Dear madams of Dr. Shashi Srivasu, madam,
fluids by like calculating the fasting deficit, then insensible losses, then maintenance amount and all. We used to give like this. But in last decade, there were many studies on the like you should give liberal or restrictive fluids. But most of the studies were on abdominal surgery where they practice restrictive fluid therapy. So, but there are if you come to neurosurgical patients, because we cannot say like this patient I am going to give restrictive fluid, in this patient I am going to give liberal fluid therapy. So actually there are certain disadvantages of both the modalities. Like if you give restrictive fluid therapy, there are kidney chances of kidney injuries and what means wound infection and all. And if you overhydrate your patient, there are chances of cerebral edema and other problems in the post-operative period. Like sometimes there is lung water also goes up and then you get pulmonary edema and all. So actually what is the best practice to give? This is what nowadays we are also practicing, like goal-directed fluid therapy, where we set certain parameters and we guide our fluid therapy according to that. That's the best way to give fluids operatively in the perioperative period also. We can give goal-directed fluid therapy because both have advantages and disadvantages, liberal fluid therapy and restrictive fluid therapy. So best is to give goal-directed fluid therapy. Thank you.
Madam, what do you say?
I agree with Dr. Shashi. Initially, we were using a very liberal kind of fluid, which would probably lead to more post-operative complications. And fluid-directed therapy is the way to go now. Only thing is, it should be measured by whatever means we have in our ICUs or in the OTs. The easiest to measure would be the blood pressure, the urine output, the lactate levels, or the SVO2. Some places where you have a lot of invasive monitoring, we can even measure the cardiac output, the stroke volume variation, or the pulse pressure variation. Even some people even measure the pleth variability index. So whatever therapy we use, restricted may have a disadvantage of causing renal dysfunction later, but whatever therapy we use, it has to be monitored continuously. I mean, this is such a dynamic process that we can't stick to one kind of therapy. If there is blood loss, we may have to give more, but the monitoring, continuous monitoring of the dynamic parameters have to be done. So earlier, I think we were not using the monitoring so much, but now with the dynamic monitoring easily available in some hospitals, we should monitor all these things.
So nice, madam. Both the ladies come to the consensus of the things.
Now, I would like to put this question to Dr. Punanya. The consensus which is emerging is that the goal-directed fluid therapy is the way forward. So currently, what is the evidence saying regarding this?
Rahul, as you said, the way forward is the goal-directed fluid therapy. Whatever said and done, in our practice, if you retrospectively review in most of the patients, we overload the patients with a lot of fluids. Fluids like antibiotic has to be used very judiciously. We have to follow the same principle, like how do you select the antibiotics? We need to have a fluid stewardship program. And goal-directed fluid therapy, and there is a caveat in that. So to what goal we titrate the fluid therapy? Is it to the CVP or the SCVO2? Is it to the IVC collapsibility, or is it based on SVV, PPV? So we have so many variables, or it's titrated to a perfusion variable like a lactate or capillary refill time or urine output. There are so many variables, and we have to mix up a lot of variables to arrive at a very precision medicine kind of tool. So yes, goal-directed therapy is emerging, and there are a lot of evidence which favors that, in the sense we tend to administer less fluids than if you go with a conventional fluid management pathway. So in that way, by avoiding fluid overloading, by directing our therapy to specific goals, goal-directed therapy is emerging, and a lot of evidence are favoring goal-directed therapy in neurosurgery and neurocritical care, in general critical care as well. Yeah.
Thank you, Dr. Punaya. You have brought out a very important point that the fluids have to be considered akin to drugs. And same way, for the prescription, we have to have a fluid program. So, and second thing which you have already brought out is that all our fluid management has to be directed towards a variable, and accordingly, we should choose a monitor to monitor that variable.
As both the professors of Dr. Shashi and Dr. Jia madams told, and now with the precision medicine, what he's talking about, Punaya, what exactly, how do you really go with the hemodynamic goals and the dynamic parameters to be evaluated for practicing this goal-directed therapy? Sir, I request Dr. Ankur to say about it.
Yes, sir. So we have been talking about goal-directed fluid therapy, but to what monitors should be used? What should be the hemodynamic goal? So there are certain static parameters which we used to use earlier. For example, the most important one is the mean arterial pressure, which we must keep more than 65 to 70 millimeters of mercury, and targeting a cerebral perfusion pressure of at least 60 to 70. That is what has been laid by even the Brain Trauma Foundation guidelines, because if we go more, we'll land up in pulmonary edema. If we go with less, then we'll land up in cerebral ischemia. So it becomes a kind of a double-edged sword. Apart from that, we need to have normal cerebral oxygenation. We need to maintain urine output of more than 0.5 mils per kg per hour, and then normal serum lactate, then a central venous oxygen saturation of more than 65%, then CVP of around 8 to 12. But these were all static parameters, and they had a lot of problems with them. So the more dynamic parameters that have come up both perioperatively, both intraoperatively, as well as in the critical care settings, we have the simple placing of an arterial line, and from that we can go in for a systolic pressure variation, which is nothing but, as we have said, that it is the maximum systolic arterial pressure minus the minimum, which basically changes with expiration and inspiration divided by their mean into 100, and that value between around, say, less than 13%, we should be able to target that, because if it goes more than that the patient is definitely fluid responsive and we can administer more fluids to it. Apart from that, we have simple plethysmographics, so we can calculate PPV in a similar fashion. We have pleth variability index, which is a fraction from 0 to 100, and accordingly we can see, depending upon what is the perfusion index of the patient, we can calculate that variability index. With that, we have stroke volume variation. Then we have IVC, simple ultrasound of an IVC will give the diameter, if it is less than 2 centimeter and the collapsibility is more than 50%, or in mechanically ventilated patients, if the distensibility is more than 18%, then in those cases you need to administer fluids to fill up the volume. Otherwise, the volume status is the patient is hypovolemic. Similarly, then we have a this 2D echo, that is the transthoracic, or the in OT setting, we can even do a transesophageal echo, where we can land up with a 5-chambered view, see the aortic valve, see the LVOT VTI, that is the left ventricular outflow tract velocity time integral, and that is the variation with beat to beat should be ideally less than 12%. If it is more, then we can administer fluid. Similarly, the end diastolic area of the left ventricle, the kissing papillary sign, that is the papillary muscle movement which is taking place in the transgastric view, if that is taking place, that means the patient is hypovolemic, or the end diastolic area is less than 10 centimeters square, that indicates patient is hypovolemic. More than 20 centimeters square, it indicates fluid overload. So we should try to keep it between 10 to 20 centimeters square. So these are all the various parameters. Through an arterial line, through plethysmography, through echo, through ultrasound, we can actually go for the dynamic parameters, and that will lead us to more goal-directed fluid therapy administration and will lead to better outcomes in these patients. Thank you very much.
Excellent explanation, Dr. Ankur, within a short time, and definitely only arterial line and ultrasound in the ICU and the OT is going to really give us a lot of benefit. Thank you.
Now it's time to move from the neurosurgical OT to the neurosurgical and the neurological ICU. And I would like to put forth this question because vasospasm and delayed cerebral ischemia is one of the commonest complications which any neurointensive would encounter in the neurological or neurosurgical ICU. I would request Dr. Jayas to throw some light on the fluid therapy management, including fluid therapy for managing vasospasm and BCI.
Yeah. So I think all of us have dealt with patients with DCI. Our neurosurgery and neurointensivist friend would always like to load the patient with 5 liters of fluid. But now again, the consensus for triple H is gone out of vague. Main thing is to maintain the systolic or the mean arterial pressure. And we have not been using colloids or albumin, neither hypotonic fluids like Ringer. We use crystalloids, mostly normal saline. And the European Society has also put certain guidelines. While we are treating delayed cerebral ischemia, certain things should be monitored, like the arterial blood pressure, the reversal of neurological deficit. That is very important. If your therapy is adequate, the patient's neurological deficit will reverse. Another thing which we can monitor, if we have a TCD, we can see the improvement in cerebral perfusion by decrease in the velocities. And another thing on CT perfusion, if it is easily feasible, we can also see the improvement in cerebral perfusion or the reduction in the mean transit time on CT perfusion. The end diastolic volume index is another thing which we can measure in the ICU. So whatever fluid we are giving, it should be monitored using a multimodal approach. Later on, we can also measure the lactate, urine output. All these are very easy to monitor, the SVO2 levels. We can even measure the osmolarity or the electrolytes. So all this will help us guide to the fluid therapy. And usually we like to maintain an intake of around 3.5, not more than 4 liters per day if the cardiac status and the lungs allow. So usually this is our approach of using crystalloids and multimodal monitoring.
Thank you, Dr. Jaya, for bringing out a very important factor that, again, what we are practicing is a goal-directed therapy here also, where we are continuously monitoring by the various monitors which you have said, and the triple H therapy has now gone out of vogue.
Sorry. As I understand that the importance of ultrasound machine and TCD and intra kissing sign of the heart and everything is important to have the fluid management. I request our Punaya sir to just say that whether is there any current guidelines of fluid therapy for traumatic brain injury? And as you said, dynamic parameters are very important. Is there any role of ICP monitoring to guide the fluid therapy, sir?
So the Brain Trauma Foundation guidelines is the gold standard guidelines for guiding the fluid therapy in traumatic brain injury. As you all know, the guidelines always recommend crystalloid solutions. And we already had a discussion about normal saline versus balanced crystalloids. Always the guidelines recommend against using colloids or albumin regularly. And also to avoid dextrose containing solutions. So I think in most of our practice, the dextrose containing solution is almost out of practice. So the guidelines are pretty standard for so many years that we are practicing. It's only crystalloids. And now we are directing it more towards how to use the crystalloids rather than thinking about what is the alternative for crystalloid. We're thinking about how to use that judiciously, at which phase, what fluid, in resuscitation phase, how to give, and during stabilization and during optimization, and how to evacuate the fluid also once the resuscitation is completed. That's also very important because it forms a vicious cycle, and we are ultimately worried about the overall outcome of the patient. Yes, ICP monitoring should be used when it is indicated, and it definitely helps us to titrate our therapies. Specifically to fluid therapy, yes, in terms of giving hyperosmolar therapy, we can use ICP monitoring, and we will come to know whether our therapy is working or not, rather than giving it blindly. Say start 3% NS, 50 ml per hour, 20 ml per hour. Instead of that, when you give a therapy, a hyperosmolar therapy, we'll be able to know whether it is working or not with the help of the monitoring. In that way, it's very helpful.
So as you said that it's going to be helpful, it's not going to guide us actually, and it's really helpful. Anyway, thank you, sir.
I would like to put forward this question to Dr. Ankur. Dr. Ankur has described very well the various hemodynamic goals and the dynamic parameters to be evaluated while practicing goal-directed fluid therapy. So in the neurological ICU, which monitor would you like to use or which parameter would you prefer? And would it be perfusion based or a hemodynamic goal based?
Again, thank you very much. Clinician, how to assess fluid status? Like as I have already said, that there were various static parameters which you used to have initially, like a CVP monitoring or a capillary refill time or a pulmonary capillary wedge pressure based upon surviving sepsis guidelines. And there are so many other things that have been laid down by the various guidelines and various foundations as far as the intensive care is concerned. But specifically in neurointensive care, we have problems because these patients have raised ICP, even the passive leg raising test. Just a simple test cannot be that accurate as in other general ICUs because of the fact that these have different abdominal thoracic compartments and the pressures are different. Their intracranial pressure is raised and patients we may not be performing that leg raising test so easily. So the other markers include like your basic recommendations for simple ABG, which is giving a base deficit, which is giving lactates, like the gastric intramucosal pH, which is sought out from the gastric tonometry, which measures indirectly the capillary perfusion or the microcirculatory blood flow. These are one of the things which we can use as basics. Then the other ones are the cardiac output monitoring, which we can do in our ICUs. That is, the gold standard is the transpulmonary thermodilution guided, and the less invasive ones include esophageal Doppler. And again, we have the others like your LIDCO is there, the pulse contour analysis techniques, the lithium dilution techniques. But these are all again based using your specific equipments if you have availability of those equipments. And secondly, also if you have these availability of because arterial line is everywhere. So most of the things, the cardiac output monitoring these days are being done using your arterial flow track measurements and calculating the various parameters through a simple basic arterial source. Then others are like more complicated ones. We are not using thoracic bioimpedance and all. Then as far as the basic dynamic parameters which have already enumerated regarding systolic pressure variation, pulse pressure variations, and regarding ultrasound monitoring of the IVC, and then of course the transthoracic echocardiography, which I have told. So they are all depending upon how what equipments are available to you and what all how accurate can these perform in the setting of the patients with in hypovolemia and associated with raised ICP. And another important volumetric measure of preload is what is called as the global end diastolic volume index. That is also normal values being somewhat around 680 to 800 mils per meter square. So that is also measured using this transpulmonary thermodilution guided. So there are various n number of equipments which are available to monitor cardiac output, to monitor the fluid status of the patient in a neuro ICU. Thank you, sir.
Thank you, Dr. Ankul, for beautifully, you have so very well brought out the various things which have to be done. But what is important is that one size doesn't fit all. So along with the fluid therapy, the monitoring, assessment of fluid status also has to be individualized to the patient.
Very important.
And with laying equal stress on the clinical method, on the basic EVG, as well as the whichever monitor we have, whether it's invasive or non-invasive. And nowadays, with a simple arterial line can tell you multiple things. So we are moving from invasive towards a less invasive method.
Yeah, madam, as you know that in neuro ICU, once because most people are unconscious, it takes a long time. The early suspicion should be the sepsis, and particularly when the traumatic patients comes and do the surgery, they are likely getting into the sepsis and they can go into ARDS. So what is the best fluid strategy in these patients, ma'am?
This is a very complicated fluid management strategy. Actually, if you go by the surviving sepsis guidelines, you have to give around 30 ml per kg in the first 3 hours, which would amount to around 1800 to 2 liters of fluid. Whereas if the patient has ARDS, then because of the increased permeability of the alveolar capillaries, there's a lot of leakage of protein-rich fluid. So we would use a restrictive fluid therapy with diuretics. So we would try to dehydrate the patient to some extent. But this again would cause multi-organ failure due to decreased perfusion. We would not like to use too much of fluid in a head injury patient. It would be counterproductive. It may cause pulmonary edema. So the recommendations again suggest use of a transpulmonary thermodilution or a pulmonary artery catheterization or a monitoring of cardiac output to evaluate the fluid responsiveness so that the extravascular lung water does not increase. So maintaining a balance in this case would again be very, very tricky and would require multimodal monitoring. I think the take-home message would be to have multimodal monitoring in the ICU. Otherwise, these patients really, they land up with multi-organ failure due to restrictive fluid therapy, which we would like to give to patients who have increased ICP. On the other hand, they can go into multi-organ failure very rapidly with this therapy. So using the multimodal monitoring, as Ankur has pointed out, whatever is available in the ICU, that should be used and which should be guiding the fluid therapy.
It was so nice, madam, for giving us the insight into this.
It is a difficult situation, no doubt.
Yeah, I understand. And definitely, I think with the time permits, we can discuss further, but I would like to summarize up to some few points because as Dr. Rahul sir, can I summarize or you would like to have some more questions?
I think time is almost up, Dr. Mohan, so
Yeah,
we should quickly summarize.
Sure.
And let the audience also ask questions towards the end. We'll have to keep some time for the
We give
audience.
time for
also.
audience to ask questions for the esteemed panelist we have is very nice. And just to summarize our association for the fluid management of neurosurgery and neurocritical care. Sure, it's inappropriate intravenous fluid administration is associated with the post-operative complications and increased mortality, which we really don't want it. So, and at the same time, as hypotonic solutions and colloids should be avoided in neurosurgical patients. And the treatment with the balanced isotonic crystalloids is preferred over administration of normal saline, even though it's time tested for a long time. And the Sashi madam actually explained it along with the Jaya madam. And the choice of fluid during the neurosurgical procedures depends largely on the patient's clinical condition, particularly renal function. We all know about it. But what I understand is that now, as we all not looking into only static parameters and dynamic parameters and variables are very important. And as you said, that neuroanesthesiology is not just learning the EMG and EEG and those kind of things. We should really know about ultrasound and looking at all variables, which you're all experts and senior anesthesiologists to do it. That's what the learning process should be there. So this is what we understand, what the points we should take home and looking into this. And thank you, the organizing committee, and thank you, Dr. Rahul sir.
Thank you, Dr. Rahul, Dr. Mohan.
Thank you, Dr. Rahul, Dr. Mohan.
Thank you, Dr. Rahul and Mohan.
It was an excellent moderation of the panel discussion.
Yeah, thank you. I would like to thank my fellow moderator, Dr. Mohan Maharaj, for helping out, and actually he took the lead in planning the session. At the same time, the esteemed panelists, Dr. Shashi ma'am, Dr. Punaiya, Dr. Navdeep, Dr. Jaya, and Dr. Ankur stepped in, and they shared their valuable experience and ideas, spared their time. So I'm really indebted to them. And now, since it's a virtual meeting, so we would be now, the entire panel is available to take the questions from the August audience. Thank you.
Thank you.
Thank you. Thank you.
Thank you.
If there are any questions on the panelist, and we are ready to take it.
I believe there are no questions. There are no questions in the chat box. There are only two inferences out of that. Either we have done a wonderful job so that everyone has understood everything. And I would not like to infer the second. I would like the second choice to be left to the imaginations.
It's a congratulations to the entire team, and congratulations to the ISA organizing committee for conducting the national conference very grandiously and nicely. And thanks for the opportunity.
Yeah, we are deeply obliged to the organizing committee led by Dr. Rashesh Diwan, the organizing chairperson, Dr. Bhadresh Shah, the organizing secretary, Dr. Tallika, the scientific chairperson, and Dr. Aditi, the coordinator, for providing this opportunity to share our experiences with the August audience attending Isacon 2021, physically as well as virtually. And a big thank you and a token of appreciation, gratitude to my fellow moderator, Dr. Mohan, and the esteemed panelists for stepping in and doing their bit. And I hope we've been able to complete this panel discussion in time.
And thanks to the tech team.
Yeah, the tech team, the real heroes behind the team who have been working tirelessly to make this virtual or hybrid conference possible.
You're welcome, sir. You're welcome.
Shall we close it?
I think there are no questions. I think we can.
No, sir, no question in chat box.
Okay, we'll close mistake team.
Thank you, everyone.
Hello. Yes, my program
morning.